These are the four major functions that will be performed by nucleotides. Now let us have a look at the structure, how they look like, how they feel like. From today's class henceforth, I will expect you to know the meaning of the words you are uttering. If you are sprouting the word gene, I expect you to know what it means. If you are saying hormone, then I expect you to know what hormone is. Okay? After today's class, you are not going to mouth a word whose meaning you do not know. If you do, you are in dire status. Are we clear on that? I cannot hear a yes, sir. Yes, sir. Good. Nucleotides, NP, they are basically composed of three parts. First is a complex base. Second is a ribose sugar. I am oversimplifying things for your understanding. We'll get into the complicated part little by little. And then you have, yes, louder, right answer, phosphate groups. Then you have phosphate groups. Okay. Now in this complex base, there are two major players. First is purine base. Purine base. And the second is pyrimidine base. Now follow my actions, just how I pull them on your copies. You are going to carry this your entire lifelong. First of all, write an N. N. Then put it in a hexagon. N. Done? Easy till now? Easy peasy chicken sleazy? Right? Easy. Anybody having difficulty yet? Mouth up, man up, speak up. If you don't, please leave. Don't bore me. I am here to have an interaction. I do not want a dead crowd. After this, put a 5-member ring with 2 nitrogen. N. And that's it. This is a purine ring. How hard was it? How hard was it? It's a purine ring. See? And put 3 double bonds here, 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 and here. You are done with it. So easy. Once again, repeat. Rinse and repeat. N. It's complete. Put a pentagon. Done. That's your purine ring. Put 4 double bonds. 1, 2, 3, 4. Yeah, you're done. Officially done. So this is your what ring? Purine ring. So this is the base on which you got to work upon, you know. This is the base of which you want to work upon. Then what do? Then you remember 2 names. One is adenine. Another is guanine. Adenine and guanine. But all rings, including wedding ones, have numbers. Okay? All rings have numbers. So here, you need to know how to number them. Any fat ideas? Remember the N, how it all started with a Big Bang. Any Big Bang Theory fans over here? No, absolutely dead crowd. Good for nothing. Okay. So, 1, 2, 3, 4. 9. That's how you number it. Start with the N. 1, 2, 3, 4, 5, 6, 7, 8, 9. It goes on clockwise in both places. Easy till now? All you need to do is draw an N, draw a hexagon, Put a pentagon at its side, put 2 ends and 4 double bonds. That's it. That's your purine ring. Now you want to make an adenine out of it. Now you want to make an adenine out of it. So 2 amino 6 oxopurine is your adenine. And do put the double bond. Okay, done. Easy till now? Easy till now? Everybody drew? Shobai ekecho? I started with an N. So adenine is 6 aminopurine. Guanine is 2 amino 6 oxopurine. Very good. That's how you remember it. That's how I was taught in my college. That's how I want to teach you people, so that you can carry it home. Till here was basic purines. Till here was basics. There are some other purine rings as well. Okay? Words that you are very knowledgeable about. Xanthine, hypoxanthine, uric acid. Xanthine, hypoxanthine and uric acid. Okay? So how do you go about it? Draw the purine ring. How do we draw the purine ring? N, hexagon complete, pentagon N, put the double bonds. Put an oxo at 6th position, xanthine. Put another oxo at hypoxanthine. Put an oxo group over here. This is uric acid. This is uric acid. So these are called extra purine bases. What are they called? Shout aloud. Extra purine bases. Now see, you have beautifully placed double bonds, right? Beautifully placed double bonds. Where there are double bonds in a cyclical notion, what happens? What happens? Yeah, right. You are right. Speak it out loud. Resonance happens. Resonance happens. So here, if we resonate this ring, the structure will come like N, 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 N. Okay? Now resonate it. OH, 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 OH. When you remove this OH, this structure should become like this. N, 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 O, O, O with only one double bond in between. And this one, these two are called lactam-lactim isomers. What are they called? Louder! More louder! Lactam-lactim isomers. Okay? They are called lactam-lactim isomers. You have drawn? Okay. Drawn? Anybody who has not drawn till now? No one? All have drawn? Raise your hands, those who have not drawn till now. Not finished drawing? Complete it. Complete it quick. We need to get into pyramids. Done? Who is your CR? Class representative? Huh? Not yet decided? Then I will pick a CR for you. You there? Yeah, that nice boy in that white shirt. Yeah. Just beside you, who's trying to look down and avoid my gaze. Yeah, you. Come. Yeah. Come out. Quick. Quick, man. We don't have much time. Quick. Run. You can't run? Okay. Be a dear and wipe the board for me, please. Okay. So now we are going to get into pyrimidines. What are pyrimidines? What are pyrimidines? They are what? What kind of bases? Nitrogenous bases. Okay. Thank you. Be a dear and sit in front because I will call you again. Okay. So how do you draw a pyrimidine ring? Again, super easy. It all starts with an N. It all starts with an N. So N, N, N. Okay. And that's it. That's your pyrimidine ring. As simple as that. Now, in pyrimidines, you have, I remember it like this, U, P, and C. How do you number them? Numbering starts at N. Numbering starts at N. 1, 2, 3. Sorry, here the numbering starts from lower one. One, 2, 3, 4, 5, 6. Okay. So this is your pyrimidine ring. Now you have U. U stands for uracil. Okay, very good. Uracil. T stands for amidine. C stands for cytosine. Okay. So in uracil, you put 2 oxo groups. Okay. You put 2 oxo groups where on and so double oxopyrimidine is uracil. Now put a methyl position at third. Put a methyl position at the third point. So 1-methyl double oxo pyrimidine is your thymine. Now remove this methyl group and put an NH2 on top. This becomes your cytosine. Now do you think you will have trouble writing these structures? Do you think? Of course not. Because how many structures have you drawn till now if you have followed my cue? More than 12. You have practiced it enough. That's why for this particular lecture, I asked you to get your copies out and draw the rings with me. If you have done this exercise, it will remain with you for lifelong. If you have not done this exercise, you are on your own. You are a big man now. Okay, universal suffrage, right? Equal rights, equal duties. So there you have uracil, thymidine, and cytosine. So that's your nitrogenous bases that compose 1/3 of your nucleotide structure. And now we have to deal with the what? Sugar part. And sugar part, what we have? Ribose. Very good. Now, you are done with your carbohydrate metabolism, right? Done with your carbohydrate metabolism. You haven't done carbohydrate metabolism. Really? Okay. So, you do not know the pathways, you do not know glycolysis, you do not know electron transport chain, you have not been taught glycogenolysis, glycogenesis and all that. You have not been taught? Okay. Where you taught HMP shunt? Hexose monophosphate shunt. Okay. See, hexose monophosphate shunt is an accessory pathway. It gives you plenty of different cyclical sugar structures. Okay. It gives you 3 carbon cyclic structures. Name it trihalols. It gives you 5 carbon structure. Name it ribose and ribulose. It gives you 7 carbon structures. Heptulose and pseudoheptulose. All of these are necessary. Along with that, HMP shunt allows you to generate NADPH, not NADH, NADPH. And this NADPH is utilized to maintain the integrity of your RBC membranes. And there is another important major role played by G6PD, glucose 6-phosphate dehydrogenase. So that is why if this enzyme is deficient, the person is suffering from malaria, you give the person quinine and then you give the person primaquine. Whenever you use the drug primaquine, the reactive oxygen species in your body increases. And if you do not have sufficient quantities of NADPH, your RBCs will break down within your blood vessels, and that condition is called intravascular hemolysis. And NADPH is the only thing that is allowing your RBCs to protect its membrane. It is allowing your RBCs to squeeze through those fine capillary systems that is present in your spleen. And that is how it enables your RBCs to have a lifespan of 120 days. 120 days for whose RBCs? Your RBCs. If I give you RBC, if you get a blood transfusion, do you think your RBCs are going to last that long? No. Why? Insufficient presence of NADPH. That blood has been stored for a long time. So that is why hexose monophosphate shunt is a very important pathway which will appear in each and every exam. Not only talking about your undergrads. It will appear in your postgrads. It will appear in your PG entrances. It will appear in your super specialty entrances as well. Has to. Okay? So, we have ribose. A very easy structure to draw. Very easy. It all starts with an O. Comfortable till now? It started with an O and you put a 5-membered ring. Then what you did is 1, 2, 3, 4. Just like glucose. 1, 2, 3, 4. CH2OH. Very good. So this is your ribose. This is your ribose. Now if you remove this bad boy from here, it becomes deoxyribose. It becomes deoxyribose. Okay? And you number it like this. 1, 2, 3, 4, 5. You number it like this. 1, 2, 3, 4, 5. Okay? Cool. Easy. Easy till now. Easy till now. Now, this OH is gonna hit this bad boy over here. This OH is going to hit that bad boy over there, and it will form a phosphodiester linkage. It will form a phosphodiester linkage. What linkage? Louder. Once again. Very good. It will give you a phosphodiester linkage, which is the strongest natural bond present in nature today. And due to this reason, it was selected by evolution to carry your hereditary genes and proteins. You cannot break it easily once it has formed. Very difficult. Very, very difficult. So now we had a nitrogenous base. We had a ribose. We put it together. Put it into a phosphodiester linkage. What did we get? No, we got a nucleoside. We got a nucleoside. We haven't reached tide yet. Okay? When will you reach nucleotide? Yeah, the phosphate has to replace this big bad OH over here. 1 phosphate, mononucleotide, 2 phosphate, dinucleotide, 3 phosphate, trinucleotide. And that trinucleotide structure is your completed nucleotide structure. Are we clear? So here you should put a P, and you put another P, and you put another P, and then your nucleotide structure is complete. Easy till now? Easy till now? Any questions? Any doubts? Very good. So here you have your first completed nucleotide structure. Always remember, until and unless the phosphate has been attached to the CH2OH part, you haven't reached nucleotide. It's a nucleoside. Okay? It's a nucleoside. So now let us come to, before I proceed further into the lecture, I would name a scientist. His name was Meister. In 1862, he was the first person to separate nucleic acid material from pus cells, and he named it nuclein. Later, another scientist by the name of Kosher first demonstrated the structure of nucleic acids, and he was the first person to differentiate between DNA and RNA, and both of them were awarded the Nobel Prize for their gallant efforts. Okay? So, after this, I would like to go into the discussion of mRNA. It has to go out. Go out where? Cytoplasm. It has to go out into the cytoplasm. Why? Why does it need to go out into the cytoplasm? Yes, it has to be translated. It has to be translated. And that translating mechanism is present at cytoplasm. Where specifically in the cytoplasm? Highest concentration. Where do you, that translating mechanism, maximum amount is present where, in which cell organelle? Of course, the ribosome are fitted over where? Endoplasmic reticulum, the rough one. Come on. Is the endoplasmic reticulum the rough one? The rough endoplasmic reticulum is associated with your protein synthesis. Unfortunately, there is a smooth one as well. The smooth one is associated with lipid synthesis, direct synthesis. Lipid synthesis is done in mitochondria, don't fool yourself. So what does smooth endoplasmic reticulum do? Steroidal hormone. Yeah, right. Part of it. A better answer would be? I'm making him so uncomfortable. Right? Yeah. What is the function of smooth endoplasmic reticulum? What does it do? It's the packaging industry of the cell. It puts everything in neat little vacuoles. Okay. It processes everything, right from proteins to lipids to oils, even nucleotides. All the smooth endoplasmic reticulum does is put a lipid bilayer around things. Okay, that's all it does. It's a packaging industry. So after this lecture, what should we know? Biochemical structure of ribonucleotides already completed. Then we should know the similarity and difference between RNA. You told me not to do that because you know it from your 11 and 12 days, so I'm not going to bother. Now we'll come to the types of RNA, functions of RNA, and how RNA helps us in maintaining our hereditary information. Okay? Once again, the structure, ribose structure, see, thymine is, name it, quick, 1-methyl, 2-oxo, pyrimidine. Okay? Uracil is 2-double-oxo, pyrimidine. Okay. RNAs have secondary structures as well. They have a tendency to fold upon themselves. And when they fold upon themselves, they form a tertiary kind of structure just like proteins. They can form loops, they can form bends, they can form dimers. Okay? They have the ability to form loops, bends, and dimers. See? Loops and bends, tetraloop, G dimers. Now let us come into the mRNA part. Okay. In DNA, what do we have? Suppose it has been uncoiled. Okay. This has been uncoiled. So there are 2 strands. Okay. Which one is template strand and which one is active strand? You don't remember? Which one is the template strand? The upper one is the template strand. Okay? The upper one is the template strand. And the lower one is the synthesizing strand. The lower one is the synthesizing strand. Once here translation gets completed, we have a primary transcript. Primary transcript. Heterozygous RNA, HZ RNA. Okay, it is called heterozygous RNA. And it has everything. It has got the intron part, it has got the exon part, it has got the controlling mechanisms, it has got your theta boxes, Pribno boxes, regulation, deregulation centers and everything. Do you need this entire thing just for translation of proteins? No. That is why this needs to be cut up. This needs to be cut up. And then you will have a secondary transcript. You will have a secondary transcript only having the relevant information for protein synthesis. Okay? But in your cytoplasm, there is a terrorist group. Terrorist group. They are called 3' exonucleases. So if you put this solid gold over there, this 3' exonucleases will cut it up, cut. And then you cannot synthesize your proteins. So what nature did? They gave you an army. Okay. They gave you a special task force. And that special task force came by the term 5' cap. Then you have your primary transcript, and then you have a poly A. You have a 5' cap and you have a poly A tail. This 5' cap is basically 5-methyl guanidine. The head of the mRNA, and it also gives the signal that translation starts here. Okay, it also gives the signal that the translation starts here. And sometimes some bases might be methylated for added protection. This is the completed structure of your mRNA. Basically, all of these will come under post-transcriptional modification. Okay, most of these will come under post-transcriptional modification. But without going through this procedure, I will not be able to teach you. That's why I had to go in this detail. So this is the completed structure of your mRNA. But the ultimate goal is, what do you want to synthesize? We want to synthesize what? Proteins. We want to synthesize proteins. So now this mRNA has to undergo another set of mechanism to make proteins. Okay. So what does this mRNA basically have? Triplet codon. It has got triplet codon, but it's all in the nucleotide. We want to transfer that thing into proteins. So what did nature give you? The nature has to give you a translator for this, right? What is the name of that translator? It is called tRNA or transfer RNA. Okay. So the next point of discussion will be your transfer RNA. This is what the transfer RNA looks like. Okay. And this thing mimics a leaf like this. And this is called clover leaf model. This is called clover leaf model. Any anime fans over here? Black clover? Okay. That's a 4-1. Let's put a 5th to it. Okay. Okay. So we have a clover leaf model. See, I told you RNAs have the ability to fold upon themselves to form structures. And see here, this little fella has made 4 arms out of it. Okay, it has made 4 arms out of it. And this is the adapter, is the translator to translate the language of nucleotide chemistry into protein chemistry. How? We'll come to know. I am not drawing this, it's very difficult. Okay. So here you have 4 arms. The lowermost part is called anticodon arm. The lowermost arm is called anticodon arm. Okay. Then you have the upper part. Okay. That is called the coding arm. It is called the coding arm. And then you have 2 still other arms. Okay. One, you have a DHU arm. or dihydrouridinal. What does it do? It anchors your tRNA. It anchors your tRNA on the ribosomal platform. Okay? So think of it like this. This is your ribosomal platform on which the entire synthesis is going to take place. The first thing that is going to come and fly over here is your mRNA. Okay? The mRNA is here, it is active. Okay, it is active. And at this part is your 5' methyl cap, which is shouting, yeah, I'm here, start translating. Okay. So now comes your tRNA. Suppose this is your tRNA. Let's put two side by side. Happy? Okay. So it came and stuck over here. Here is the anticodon arm which is got stuck on your mRNA. Here another thing will come. It has not come until now, but here another thing will come. And this arm, this DHU arm, what it's doing is, it's holding the entire ribosome together. That is why it's the structural anchor. It is holding the entire thing together. Now, here you have a CCA end. That is the 5' end. Okay, it ends with CCA base pairs. What does this do is, it will get hold of the necessary protein that is being coded by the triplet codon present on mRNA. So the entire structure becomes like this. First is your mRNA, then is your tRNA, and the tRNA is holding your protein. Now imagine another structure like this. They're continuously present over here. So once these two proteins come together, they come nearby. You have an enzyme called peptidyl transferase, which will form the bond between the two proteins, and the two proteins will be released from the release site of the ribosome. So this is your clover leaf structure. These are your forearms, and this appears in each and every alternate year of university examination. There is no way you can be rid of it. If you haven't read it before the night of your examination, I'd advise you to stay out of the exam hall. Clear? Comfortable? Happy? Any confusions till now? Very good. So two major players of the RNA world, mRNA and tRNA, are gone. What's left is ribosomal RNA. Ribosomal RNA. They are a tightly knit structure. Total is 80S. 80S. If you ultracentrifuge it, it will give you 60S and 40S. What is this S? 60 plus 40, 100 कैसे हो गया भाई? Yeah, it's Swedberg units. Is the speed of rotation. It is the speed of rotation in which they are braking on each other. Okay? And they are just the structural platform in which the mRNA is going to come and lie down to get translated. Clear? There is nothing so hard and fast. And all those smaller things, you know, parts of 40S, parts of 60S, I don't remember. Sorry. I do not know everything in the world. Please read it on your own. Okay? Now the only thing left is small RNAs. The only thing left is small RNAs. And they are perhaps the most difficult and uncharted territory of molecular biology today. They have been playing role in so many things that has not even been found out yet. Small RNAs, snRNAs, to start with them, they are rich in uracil. Their primary function is splicing the first big primary transcript, and shorten it into an mRNA template. That's what we know. What we don't know is they regulate the amount of translation that is taking place. They regulate the amount of transcription that is going to take place. They regulate how and how much tissue is going to be delivered from which where, so that a complete organ system can be formed. We do not know about it. They can silence genes. They can overactivate them. They can form killer diseases like prions, or they can give you life-giving gene therapy. A totally uncharted territory in which almost 100% of molecular biologists are spending their days and night to decipher this nature. So talking about them right now in your platform is going to be very difficult. But you should know what's going on. Okay? So with this, we have hopefully finished the structure of nucleotides, the structure and types of RNA, how they look like, how they get organized, and perhaps I was also able to give you a little insight about how this entire system is working. Thank you for your patient hearing.
Very good morning to everybody. What about your study? কি পড়াচ্ছিলাম বল একবার চেক ইয়েস এই একটু আস্তে জোরে আস্তে মাঝামাঝি রাখুন কানে আসছে খুব হ্যালো ফাইন so when you are dealing any patients having some petechial rashes, purpuric rashes, ecchymosis, easy bruising, deep bleeding like joint bleeding, muscle bleeding, any hematoma, such thinking must be in your bleeding disorders or coagulation disorders, right? Any sorts of injury, any sorts of cut of injury that may be small, may be large. Due to the small, primary hemostasis is enough, you already know, but for the large bleeding, coagulation cascade is important. At the same time, if the coagulation cascade is continuously going on, then there must be a problem of clot formation and that may embolise. That means dislodge for the area after the stopping of bleeding that can go into the microcirculations like brain, heart, liver, kidney, etc. and that may cause ischemia, that means the blockage of blood circulations or ischemic stroke may happen. So side by side for your 5 steps, that is the first of all injury of any blood vessels, that is a vasoconstrictions, right? Then that is a primary plaque formations, platelet plaque formations or primary hemostasis. Then the coagulations cascade. Basically primary hemostasis is a platelet plaque formation that is temporary, and then the coagulation cascade that is also called the secondary hemostasis. So whenever in your short note it may come as a secondary hemostasis, you have to write the coagulation cascade, right? So coagulation cascade means some clotting factors are there. Maximum clotting factors are released from the liver. Clotting factors means some proteins are there, and these are the synthesis from the liver, right? Now you have to understand the clotting factors name. It is written in your book. Already I have told that whatever you are going for the cascade, coagulation cascade, remember Y shape, right? That is a Y shape, this is important. What does it mean? It means that this is the intrinsic pathway and one is extrinsic pathway, and there is a common pathway. Now what are those? Factor 12, factor 11, 10th and 8, this is 10 here, and then there is a 9 and 8, and one this is a kite of 3, and then 7 is a 10, and then is a 5 and 1. One is called fibrinogen or fibrin, basically formation of activated fibrin. So in this way, this is the intrinsic factor, this is the extrinsic factor, and this is the common pathway. Any factor defect may cause any types of bleeding or coagulation disorder itself. Now my question is that which investigations is important and which part of this is important for the understanding that the patient is suffering from intrinsic problem and the extrinsic problem. Already I told you, if you taken in a blood in your test tube, right? You are puncturing the vein and you are taking some mLs, 2 to 5 ml of blood in a test tube. Then which the process is activated, extrinsic or intrinsic? Intrinsic, definitely, because for the extrinsic, that is must be some tissue injury or tissue factor must be there. That is a 3. That is the tissue thromboplastin, also another name. And this is a 7, it's a factor 7, and then ultimately 10. Whatever it may be, extrinsic pathway is very, 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 very important. Why? Because it is a short. It is a short. This is short. Means time taken is short. So any injury problem in the extrinsic problem is a emergency situations and may cause immediate actions. But in case of intrinsic, that is efficient. That is not so much efficient, but it is fast and it is slow. You are going through all over these steps must be there, and all are the as a clotting factors relieved or synthesis as a progynes, that is zymogens, that is inactive form. There's some cascade are there to activate the clotting factors to further in a chain wise. I'm coming. So first of all, you have to remember in the coagulation cascade, this is a Y. It is very easy to know that is a 10, there's a Messi. Right? Football player is a Messi is there. Is the main thing is a 10. Factor 10 is called Stewart factor. Whatever these terms are already is gone. You can name only the factors also. So I'm not going details into the name of this factor. Nobody or no examiner in the prof asks in name of this. If you know the function, is fine. But before doing this way, important factor is that von Willebrand factor is important for the cascade way, as well as calcium is important, as well as phospholipid is important for the cofactors. Now my question is that, what is the role of von Willebrand factor here? You know already the von Willebrand factor helps for the platelet adhesions, right? For the binding of the platelet 1B receptor, and the von Willebrand factors are connected to the collagen receptors, and then only the platelet adhesions count. After the platelet adhesions, platelet blebs are formed, right? Pseudopores. Already told you, there is activations, then release of ADP, then this ADP and others, thermoxine A2, etc. is released from the platelet, from the granules. So the different types of granules are there, that is alpha and delta granules. From the alpha granules, only the proteins are released. From the dense granules, all the non-proteins are released. In this way, you have to think in your hostel room. Otherwise, it is very difficult to concentrate in physiology, anatomy. In the previous year is the massacre. Okay, so I don't like that types of results. Nobody knows where the release of platelet কোত্থেকে আসে সেটাও তো দাদারা দিদিরা বলতে পারে. This is unfortunate for me also. So giving in so much stress for any lecture is very important. I am mostly sharing my personal experience also to cope in the clinical scenarios, to understand why it is important for you all for being a doctor. Anyway, these von Willebrand factors mostly released from where? Endothelial cells. It is present in the circulations also. It does not mean von Willebrand factor synthesis in the alpha granules. No, it can be stored in the alpha granules of platelet, but synthesis is from the liver. Von Willebrand factor is a protein that helps to increase the half-life of factor 8. তার সঙ্গে বন্ধুত্ব and friends are there's 8. Not only the number and not only the increase or decrease is not relations with this, is activity. The activity of the factor 8 is controlled by the von Willebrand factor. This is important. So it increases the half-life. If it increases the half-life, then already present in that half-life means কি? Half-life means একটা কোনো সাবস্টেন্সের half-life বানাচ্ছে, সে ওটা ওই মনে করে একটা 6 আওয়ার্সের একটা half-life বললাম, একটা ফ্যাক্টরিতে 6 আওয়ার্সের half-life আছে, সেটাকে আমি বাড়িয়ে যদি 12 ঘন্টা করে দিতে পারি, তার মানে সে ততক্ষণ থাকবে। half-life means আমি শেষ করে দেবো। That is called a half-life. It is mostly in your second prof MBBS, whatever it may be. It increases the half-life. মানে basically লাইফটাকে বাড়ানো হচ্ছে। That means activity is increased, not the number or the amount. Amount is not factor. So that is it. Calcium is requirement in many 2 to 3 steps. I'm coming later, and the phospholipid also is there. Remember always, this is the factor 5, right? This is a factor 5. This factor 5 is important to form a complex that is called Prothrombinase complex. Prothrombinase complex means 2 number and 2 words. Number only 10 and 5, and another word is calcium and phospholipid. This is the complex which is essential for the prothrombin to convert it into thrombin. So prothrombinase complex means these are happening 2 numbers and 2 words. Remember like that. This is the controller of each and every cascade of the ultimate fate of the due to this complex. I'm coming. Okay, now my question is that how it is started. কিভাবে এটা স্টার্ট করবে? Starting from the intrinsic factor or extrinsic factor is no matter which one is first, which one is last, is no matter. This is basically simultaneous process are there. Suppose this is the blood vessels are there, this is the blood vessels are there, and these are the, what are those? কি এগুলো? Endothelial cells, right? And then this is the collagens, sub-endothelial collagens are there. And then this is the muscles, smooth muscles are there, are also here, right? You already know that is the vasoconstrictions is important, and for the vasoconstrictions, 3 theories are there. Anyone who can tell you the 3 theories for the vasoconstrictions? Anyone? How this vasoconstriction occurs after the injury? কেন হয় vasoconstrictions? একটা ভেসেলকে কাটার পরে ভেসেলের কনস্ট্রিকশনস কেন হয়? Reason. It is a cause, but how? How it is possible? That some theories are there. That is a myogenic theory. One is a neurogenic theory is there, and one is the endothelins. So from the cutting injury, suppose this is the cut injury is there, and from this endothelial cells some release of endothelin. Endothelins are released. That is called endothelins. So endothelins are released, and that acts on the receptor of this smooth muscle receptor and causing the contraction of the smooth muscle and vasoconstrictions done. Now the second is a myogenic, also the constriction. Myo means muscles. The smooth muscle contractions happens after the cut. Now the neurogenic, pain hoy. Katle pain hoy na? Nociceptors are present. Already in the previous already told, in between this collective tissue and the collagen fiber and the smooth muscle, there is some sorts of nociceptors are there. Nociceptors, noci means painful. Nociceptors মানে একটা receptors যারা পেনকে সেন্সেশন করে। So this type of receptors will be stimulated. Suppose এখানে একটা receptor আছে, এরকম একটা receptor আছে. These are the nociceptors. Receptors are present between the connective tissue and the smooth muscles. And whenever you are cutting this, so some inflammations are done, right? Cytokines are released. So these cytokines activates the nociceptor, causing the pain fiber into the brain. So these pain fibers, so that we can feel the pain. Nothing else. So 3 theories are important. That is a neurogenic, that is a myogenic, and endothelin release. Nothing else. That's all. And now the question is that you already know how temporary plaque formations happens. Platelet adhesions, then the pseudopode formations, then the activations, then aggregations. For the aggregation, receptors are 2B3A. The new name is Okay, so this is 2B3A. I'm editing because it is already written in your book. I'm not like to confuse you. Anyway, those who can write in the exam, it's good. So 2B3A is essential, but 2B3A normally present in inactive form That's why ADP is released. So the conversion of those receptors are there. This is P2Y1 to 12 and P2Y1. And this conversion is the conformational changes, right? This is the conformational changes of this platelet having a receptor, and also this is a platelet. This is having a receptor. This platelet are connected, and aggregation helps with the help of some fibrinogens, right? In this way, platelet aggregations happens. Suppose this is the breaking point, right? So this is the breaking point, and this is the platelet formations is done, platelet plaque formations is done, aggregations is done, activation is done. So in this way, this temporary plaque formation is done to decrease the bleeding loss. This is sufficient for any small cut, but that is not sufficient for any deep cut or any deep injury. Must be some coagulation cascade must be invited. Now these are the platelet, and platelet surface is a negatively charged. Platelet surface is a negatively charged. So here, this is a negatively charged appear into the temporary plaque formations or temporary plaque. Negative environment is created to attract the factor 12. That is important, right? So negatively charged phospholipid membrane is present in the platelet, and that invites the factor 12, that is called Hegman factors or Hegman factor, whatever it may be, your pronunciation tends to be different to country. So Hegman factor is attracted by the negatively charged platelet surroundings, right? Then only Hegman factors are activated. Yes? Can you say something? No. So factor 12 is normally, all the factors are normally present in the zymogen state. Zymogen state means proenzymes. That is not activated at all. They are inactive. Till it is not activated, it is not to work as a clotting factors which we need. So factor 12 comes. After that, factor 12 is come in contact with these negatively charged surroundings, and then only this factor 12 you can write like that is better, and then it will come like that is the activated form. This small a represent the activated form. It's written in your book already, you know. So it is for the understanding, not for your written purpose. Always written as clotting factors like the Roman. It is already depicted. It is not my entity or my any scope to change the situations of dictum or rules or laws. Clotting factors are written in Roman. So factor 12 becomes activated factor 12. Then this factor activated factor 12 will activate kake korbe 11. Right, in this way. Now one in my mind is that what is the hemophilia C? You know already that the hemophilia A, B, but there is a hemophilia C. I don't know it is written in your book or not. But yes, factor 11 absence is the hemophilia C. Hemophilia B means is the Christmas disease, is absence of factor 9. And a classical hemophilia, that is a factor 8. This is important. And so hemophilia C is written in your book? Yes, fine. So that case is factor C, hemophilia C is here is if it is deficient, and it is less, though that may present as a hemophilia C with a bleeding disorder. So now this factor 11 is now, you in your mind will come, there is a 10 will come. No is come, no 10. 10 will come later on, it will come as a 9, factor 9. So this will activate factor 9 will come, and that will be activated this way. That is a 9 factor activated factor. Now this factor activated factor 9 and factor 8, after the increasing the half-life or activation of the factor 8, this factor 9 and factor 8 make a complex, and this complex ultimately it is having 8 also. This complex is ultimately X means 10A activated form. This is now active. Messi is not in outside the field, is come into play to goal something. So this is the common path. Now I'm some little bit focus in the extrinsic factor. Why extrinsic factor is important? Tissue. So tissues are injury. So there must be the factor of 3. That is factor 3. You can write better in this way, because in your mind, if I like that, you will see, you will tell that sir eta bolechi, ami tai eta korechi. So I am from the memorizations or to learn something. So factor 3 is coming from the tissue. This tissue factor you can say, tissue thromboplastin you can say, factor 3 you can say. 3 name is there. So it will come. It will come only after the tissue injury. That is important. The tissue injury come only after the tissue injury, and any cut may cause the tissue injury, and so the factor 3 will come, and that connects or activates the factor 7. Then factor 7 is activated, and for the activation calcium is requirement. Now in this complex also, whenever this is coming, here calcium will act. বলছিলাম কিছু কিছু জায়গায় ক্যালসিয়াম লাগে, ক্যালসিয়াম ইজ ইম্পর্টেন্ট ফর দ্য কোয়াগুলেশনস। দ্য ক্যালসিয়ামের ইউজ যখন বলবে, you can in your viva exam, if you are intelligent enough and you know the better in the coagulation system, your examiner may be asked by the calcium for the muscle contraction, but if you confident about the coagulation cascade, you may utter the term first, as I said, it can be used in the coagulations. So you are inviting examiner to in your route, not for the muscle contractions, you in your route the coagulation system, and definitely invariably each and every examiner will try to know something for the coagulations. That means you are killing time of examiner, getting marks, good marks, because you know the subject. এই আওয়াজ চলে গেছে, দেখ নেই এই ডাক রে। So in this way, this can be happened by the 3 and the 7, and then ultimately these activations of the, in this way it will come again, right? So you write a note after this class in the evening or in the late evening. In this way this is happening, and this is platelet. These are the platelets is here. Now what to make it important to this stabilized or stable form of this clot? If it is not stable at all, it is only the platelet aggregation part. Hey, sound chale gache. So in this way, this happens for this formation of some fibrin mass. Fibrin mass is important. I like to emphasize to form the fibrin mass. Fibrin mass come from the fibrinogen. That is factor 1. That is important. So factor 1 is important. 2 is what is happening to 2 is prothrombin. Prothrombin is converted into thrombin by the thrombinase complex. Will 2 inactive, it will make 2 active key thrombin, prothrombin to thrombin. Then so these 2 will act on what? Fibrinogen. Fibrinogen is present where? Fibrinogen is present or synthesis in? Fibrinogen is present in the blood. Von Willebrand factor present in the blood. Fibrinogen is synthesized from the liver. Von Willebrand factors are synthesized in the liver. So this fibrinogen is a protein, and this is inactive form, and then this will come, and then it activated into the fibrin mass. Fibrin is a monomer. Fibrin is like that, a monomer. এরকম ভাবে একটা monomer তৈরি করছে। Until you form a monomer, a polymer, and the cross-linked, then this clot will not be stabilized. মানে আমি কি করতে চাইছি যেটা এখানে মেশ তো হলো, এই যে ফিব্রিন মেশ তৈরি হয়েছে, but they are not connected, they are not cross bridge. So cross bridge like that is essential to make a bigger stable form of clot, so that the large bleeding can be stopped, and it's not be temporarily. That is not the permanent at all. That is the requirement unless the regeneration, tissue repair happens. Because the tissue injury is there. এটাকে যদি আমাকে সরাতে হয় তাহলে এর যে ইনজুরি, this tissue injury is there. That is why called the clot retraction, and then the regeneration or repair will come. But if this cross reaction is needed, then the factor 13 will help. 14 means fibrin stabilizing factor. তাহলে কি কি ফ্যাক্টর এলো এখন পর্যন্ত? ফ্যাক্টর 12 এলো, 11 এলো, 10 এলো, 1 এসছে, 2 এসছে, 3 এসছে, 4টা নেই। 4টা কোথায় আছে? 4টা আমরা ক্যালসিয়াম হিসেবে ধরি। 4টা আমরা ক্যালসিয়াম হিসেবে ধরি, অনেক জায়গায় আছে লেখা। 4 is taken as a is right, it is huge thing, it's happening factor record, and then this is come into the 10 activations. In this way, extrinsic pathway also. Hello, একটু আস্তে করে দে। So in this way, we have to target to form the fibrin, nothing else. We are targeting the formation of the fibrin. So this fibrin will form, ultimately fibrinogen will not come and activated into this. Fibrinogen will be activated until unless the thrombin is formed. Thrombin is not formed until unless the prothrombinase complex must be formed before the formation of the thrombin. So like that, in this way, prothrombinase complex means what? This is the activated factor 10, activated factor 5, calcium and phospholipids. So if it is the phospholipid and calcium and factor 5 and factor 10 activated form is present in this way complex, and this complex will act with thrombin, and this thrombin will act into the fibrinogen to form the fibrin. Fibrin is a monomer that must be some polymer. So polymer like that is like that, and then the connection must be there, connection each and every part for this cross connection or cross linked for the factor. Yes, factor 13. Factor 13 will help. Factor deficiency, factor 13 deficiency may cause bleeding disorder. So any factor of this may cause the disease. Suppose a von Willebrand disease, you know already in your bulletin, von Willebrand disease, von Willebrand factor deficiency. If it is deficient, so think about that. What will happen? It will not increase the half-life of factor 8. If it is not increase the factor 8 half-life, then the factor 9 and factor 8 complex will be unstable. If it is unstable, then the factor 10 inactivated to activations form will not form. If it is not formed, then the prothrombinase complex will not form. If prothrombinase complex is not possible to form, then we fail to form the prothrombin to thrombin. If prothrombin to thrombin is failed, then the fibrinogen to fibrin will not occur. Then the fibrin will not occur. This is everything will not occur does not mean will not occur at all, because other factors are present. Its activity will become fibrin fibers will less amount, and the fibrin fibers and monomer will be less. So in this way, von Willebrand factor disease presentations may come with the deep bleeding as well as in the superficial bleeding also. And von Willebrand factor is a genetic disease, and so genetically determined, and von Willebrand disease আমি এখনো পর্যন্ত একটা পর্যন্ত দেখিনি। Anyway, so this von Willebrand factor is helps to increase the half-life of factor 8, nothing else. But side by side, this is also important, some anticoagulant activity. Problem is that যদি এটা হতেই থাকে মনে কর ফিব্রিন করে একটা পুরো 12টা বাজিয়ে দিল। Repair already start. Who will repair? Any guess? Who will repair? You already know in the alpha granules some release on some growth factors of platelets. Platelet derived growth factor, fibroblast growth factor, then vascular growth factor, vascular derived growth factor, like that. This is a platelet derived growth factor, fibroblast growth factor, and the vascular endothelial growth factor. So these factors are helped for the repair. Platelet derived growth factor is for the regeneration of the tissue, vascular for the vascularity, that's angiogenesis, new vessels, new capillaries will form, and then fibroblast will form the connective tissue regenerations, right? Fibroblast is connective tissue regeneration will happen. So these are the factors that release from the alpha granules of the platelets. So much important, each and every step is important. If it is repaired, suppose it a repair হয়ে গেছে, now this is present, what will happen? If it is this process is continue again and again হয়ে যাচ্ছে, then fibrin formation is going on, mass is going on and on. Then there will be obstruction of this vessel repair হয়ে গেছে, তখন আর ড্যামেজ নেই, then there will be obstruction, and so the latter part of this will be bloodless. এটা বাড়তে করে দিল. This is not also not must be avoided. So some check and balance must be there, like our brake and accelerator. When we need a accelerator or to drive a car, if I go, but if you need to some brake, আমি যদি accelerator টিপে যাই তাহলে শান্তিনিকেতন মেডিকেল কলেজে আসতে হবে না, দুর্গাপুরের অর্ধেক রাস্তাতেই শেষ. So in this case also you have to check to break something. So some anticoagulant activities or anti-thrombus formations or anti-thrombotic activity must be there internally to prevent. Whenever it is needed is okay. If it is not needed, you have to stop. What are those? Tara ke? No. Tissue plasminogen activator is to dissolve. I am not like to dissolve this. I am not asking for the fibrinolysis. That's a different part. I am causing, first of all, we have to stop this coagulation cascade. That is anticoagulant activities. What are those? One, you already know, during my previous classes, the points explained that the when and where and how our blood are thinner and the fluidity state. One important point is yes, that is the thrombomodulin. So thrombomodulin thrombin complex. Thrombomodulin বেরোয় কোথা থেকে? এখান থেকে thrombomodulin complex. Thrombomodulin and thrombin complex are formed. And what will happen? It activates the protein C. And what is happen? Protein C inhibits কোন factor? No, 8, okay. 5 or 8, yes. So protein S. So protein C will inhibit ultimately. What are those? Factor 5 and 8. 5 আর 8টা কোথায় লাগছিল? 8 লাগছিল এখানে, তাহলে এটাই হবে না, তাহলে এটি গেল। 5 লাগছিল আমার এখানে, কোথায় গেল কমন? ওটা এইদিকে চলে যাচ্ছে। তো 5 ইজ তো প্রথম ভিনাস কমপ্লেক্স, প্রথম ভিনাস কমপ্লেক্সের মধ্যে 5 আছে। So these things are gone, so some reduce, right? Number 1. Number 2, antithrombin 3, হ্যাঁ নাম জানা আছে তো? Antithrombin 3, yes. These also circulatory. It inhibits the factor 9, factor 10, factor 11, and to some extent factor 12 also. So this is also antithrombin 3 is present. This will not allow too much coagulation cascade to continue. বোঝাবার একটাই উপায় হচ্ছে যে কোয়াগুলেশন কাস্কেড শুরু হলো মানে শুরুই হলো তা নয়, একটা ফিব্রিন মেশ তৈরি হয়ে গেল মানে ফিব্রিন মেশটা ওখানে রয়ে গেল তা নয়। দ্যাটস ওয়াই fibrinolysis. I'm coming later. Fibrinolysis is different thing, but you have to, first of all, you have to check the coagulation. If you don't check the coagulation cascade, this is too much tough for the fibrinolysis pathway to check the further. So first of all, you have to check the coagulation cascade, and this coagulation cascade checked by the anticoagulant activities of our naturally body. That is the thrombomodulin thrombin complex, protein C activations and inhibition of factor 5 and 8. Number 1. Number 2, antithrombin 3 are no. This is for the vasodilatations. That's only the helps for the platelet adhesion, or it is mainly the inactivation of the platelet. Nitric oxide and the prostacyclins is mostly the inhibit the platelets. We are not concerned about the platelet now at all, not at all. Platelet formation already done. Now we concerned with the clotting factors. Then what are those? Number 1 is a C1 esterase inhibitors. C1 esterase inhibitors, or it is you can inhibitors deficiency, right? C1 esterase deficiency. It inhibits factor 11 and factor 12. It inhibits the factor 11 and factor 12. It inhibitions occurs. If it is deficient, esterase হবে, এটা deficiency হবে না, C1 esterase itself is inhibiting. If it is deficient, then what will happen? If C1 esterase, আজকে গিয়ে পড়বি এগুলো, C1 esterase is deficient, then some disease is called, কথা বলছিস কিন্তু কানে আসছে, hereditary angioedema. Angioedema. এই কেস আমি দেখেছি. This is present from the birth as a swelling of the lips. Angioedema is very, so that means patients having C1 esterase inhibitor. So you can detect also genetic problem. These are all the proteins, antithrombin 3, thrombomodulins, all are proteins. So some gene control are there. So genetic mutations can cause a deficiency. Genetic mutations cause this deficiency, and that the deficiency causing the hereditary angioedema. And edema means fola. Angio means vascular. The vascular edema is there mostly present in the lips, in the upper and lower lips. তার থেকেও যদি significantly বলা হয়, that is more of lower lips. It is not your concern. I am just focusing you to check the coagulation cascade, nothing else. Now you have to check, but already is huge big fibrin mass having some big clots are established in the blood vessels. So now the blocking must be there to some extent. If we also check the coagulation, our coagulation check হয়ে গেছে, still it is present. Now it have to break, right? Break to what? Break to fibrin, to the cross linking. সবাইকে ভেঙে কুটে একাকার করতে হবে, right? নইলে কি হবে? Suppose a patients come with a severe chest pain, sudden onset. এই আমি মনে করি পরীক্ষা নিচ্ছি, হঠাৎ করে একটা sudden chest pain হলো. And chest pain means what? Chest pain does not mean স্যার আমার এখানে ব্যথা করছে, ওখানে ব্যথা করছে, এরকম নয়. Chest pain means is clenching my fist into the precordium area and I'm shut down. আমি বসে বললাম এতটাই pain, that is ischemic pain, that is called myocardial infarctions. So myocardial infarctions or MI mainly due to this blockage of this way in the coronary vessels block করে দিয়েছে. So always we use some drugs, newer drugs. Previously it was streptokinase are used. Streptokinase is a tissue plasminogen activator. So this is are used for the degradations or এটাকে ভাঙার জন্য ইউজ করা হতো. But nowadays streptokinase is not used because it is allergic, it is a harmful, it is a side effects are much more. Some costly drugs are there, that is antiplase, retiplase are there. It is highly costly, and you can save the patients if the golden period is a 2 hour. Within golden period of 2 hours of chest pain, you can save the patients. But before that, you have to identify the patients having myocardial infarctions by seeing the ECG, not only the symptoms. So this is the clinical applications of this cascade, the coagulations cascade. After the coagulations formations, you have to now cut the fibrin fibers. এবার আমাকে ফিব্রিনকে কুচি করে কাটে ফেলতে হবে. কাটবে কে? প্লাজমিন. কোত্থেকে আসবে? প্লাজমিনোজেন কোত্থেকে বেরোয়? প্লাজমিনোজেন লিভার থেকে বেরিয়ে ব্লাডে থাকে. So plasminogen is not at all activate after to plasminogen. This is a term is this gen means generation of plasmin, right? Plasminogen, gen means generation. Plasminogen, this means plasmin generations. These molecules is a generations for the generation of the plasmin. So plasminogen is released from the liver and into the blood to converted into the plasmin, right? But during this period, tissue plasminogen activator, tissue plasminogen activator will be activated, and also to some extent here phospholipid also has some role. Plasmin will form and this plasmin will break. কি ব্রেক করবে? প্লাজমিন ফিব্রিন কে, it will break fibrin কিসে? এইখানেতে অনেক বড় বড় জিনিস আছে, আমি চাইছি একটু তোদেরকে জানাতে, আমি জানিয়ে দিই. Plasmin not only acts on the fibrin, plasmin acts on fibrinogen also. In the COVID area, you already know, if any relative of this, that time the doctors are very concerned about the D-dimer levels, right? D dimer levels are very much important. Jar joto D dimer levels are mortality rate toto high. So where D dimer is coming? D dimer is coming this pathway. How? I am telling you. Plasmin is activates both in the fibrinogen and also fibrin. এটা হচ্ছে ঠিক কাঁচির মতো ক্যাচ 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 করে কাটছে, রাইট? সো এটাকে যখন কেটে 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 করলো, এটার নাম হবে ডি ডাইমার। কেন আসছে ডি ডাইমার? and this will call the fibrinogen degradation product. এটা তোদের বইতে কি হবে আছে আমি জানি না, প্রবাবলি এটা থাকবে না। রিমেম্বার, always remember that tissue plasminogen activator acts on two types of plasminogen. One is specific, one is non-specific. Specific means what? Fibrin specific. তার মানে যে প্লাজমিনোজেন ফিব্রিনের সঙ্গে কানেকশন করছে সে হচ্ছে ফিব্রিন স্পেসিফিক প্লাজমিনোজেন অ্যাক্টিভেটর। ফিব্রিন স্পেসিফিক টিস্যু প্লাজমিনোজেন অ্যাক্টিভেটর, প্লাজমিনোজেন অ্যাক্টিভেটর, ফিব্রিন স্পেসিফিক। আরেকটা আছে নন স্পেসিফিক, নন স্পেসিফিক টিস্যু প্লাজমিনোজেন অ্যাক্টিভেটর, রাইট? নন স্পেসিফিক মানে কি ও ফিব্রিনের সঙ্গে জোড়া আছে কি না আছে ও দেখার দরকার নেই, প্লাজমিনোজেন আছে মারছে, প্লাজমিনোজেন আছে মারছে। So plasminogen, when it is connected to the fibrin, then some drugs are released, and then only some drugs are acts, and that is why tissue specific fibrin specific plasminogen activator means some new drugs, that is reteplase, altiplase, এগুলো এই যে altiplase, PLASE, okay? So you no need to memorize the drugs, but remember it is used for the myocardial infarction treatment to release the block or clot, right? So what is that? It is a tissue plasminogen activator only, nothing else. But again it is important যে এই যে fibrinolysis activity আমি বলে যাচ্ছি, if it is enhanced again, that is not suitable regeneration of the tissue at all, bleeding does not stop too much, less bleeding is going on, then fibrinolysis is occurring. What will happen? Bleeding will increase. Bleeding will increase. Fibrinolysis means কি ক্লটটা dissolutions করছে। Dissolutions করার কথা হচ্ছে after the repair. If it is happens before, that means sub checkpoint is there. So two checkpoints are here. One is checkpoint is a coagulation cascade checkpoint. Another is a checkpoint is a fibrinolysis checkpoint. That means some anti-fibrinolytic pathway also there. That means some anti-plasmin activity must be there. There must be some tissue plasminogen activator inhibitor must be there. বোঝা যাচ্ছে? Little bit same thing is coming in your mind, so some neural connections must be there after reading go and go. It is not so easy in a one class you can remember everything. But you go through this in book and remember the two checkpointers there. Go through a good book or good journal or anything else, and you will see that that what I am trying to say. What I am trying to say. If any problem come to me, so remember always the coagulation cascade does not is a continuous process. হতেই থাকবে তা হতে পারে না. So some checkpointers there. Already I explained the checkpoints. That is similarly fibrinolysis হতেই থাকবে বা হয়ে গেল আগে তা হবে না. That means some anti-fibrinolytic pathways must be there. So plasminogen or plasminogen inhibitor, anti-plasmin are there. Some names are there. I am not trying to gather in your brain today at all. Already lots of information is now going on in your mind. Already in your biochemistry class you have done for the 10-6. That is not possible for each and every students. If the 10 minutes gap is essential so that AMs, BH only got all the classes are up to the 9:50. That is why I advise the academic coordinator, Dr. Ryan, that to change the protocol, and that has been changed already. Okay, so 9:50 is enough for your class. But unfortunately, you are in gathering in brain. Then I am coming, and then again I am starting the coagulation cascade. So it is brain must be some settle down point is there. It is a science. It's not that. Yeah, আমার পড়ানো হয়ে গেল। আমার পড়ানোটা কতজন বুঝলো বা বইয়ে বাড়িতে গিয়ে কতটা that is essential. I am not asking for 10% student will not. কারো কারো মাইন্ড আছে অন্যদিকে, কারো কিছু ডিস্টারবেন্স আছে, কেউ এখনো সেটেলই ডাউন করা পারেনি, জাস্ট কামিং ইন দ্য MBBS ক্লাস। So lots of it there. That's it. It happens up to the only 3 to 4 months. It happens for all also. So try to adjust in every each and class, to try to adjust to of your faculties, try to adjust what is your faculties or your professor, assistant professor is telling. To some extent, your important points must be there to remember, and you can write also the remembering that point. That is the issue. Not that আমি মুখস্থ করে আমি চলে যাবো, যা পারি আমি লিখে দেবো, নো, হবে না, ভুল হয়ে যাবে, অত মুখস্থ করতে পারবি না। So to some extent knowledge gatherings must be there. To some extent you can, যদি কোশ্চেন ঘুরিয়েও আসে তাহলেও যেন আমি ওই দিকের ট্র্যাকে ঘুরিয়ে লিখতে পারি, at least to get the pass mark. Now my target is to get the pass mark, not the 80-90%. No, not at all. It's not possible at all. So, but it is possible to get the 50 marks, 100%. It is possible if you continue to do your study, continue after you thinking the what is the lecture is going on, and always clinical implications think. Why we are doing so much things, what is the implications of that, then only you can get interest, otherwise no. If you don't know the von-Willebrand disease, hemophilia and other things, that is the petechial, purpura, then you will look after in your relative also. If your relative, any children, on your own brother, own father, own mother, own grandmother, some sorts of skin rashes are there, who is telling, someone is telling that some episodes is continuously doing on, at least before the going to the hypertension, you will keep in mind that some bleeding disorder, maybe something is problem, or bleeding disorder does not happen one day. And also, remember also, this liver is a source of some proteins. So any bleeding disorder, we have to check the liver status. That means chronic liver disease, vitamin K deficiency. Vitamin K deficiency for what? Vitamin K deficiency is important for the clotting factors. KK. 2, 7, 9, 10, তাই তো? 2, 7, 9, 10. So these are the vitamin K dependent. That is why after the newborn delivery, we always give the vitamin K একদম বাটকসে বেরোবার সঙ্গে সঙ্গে ভিটামিন কে দিয়ে দিলাম, irrespective of any, don't know anything, anything happens. So your homework is von-Willebrand disease, hemophilia, right? And the others like ITP. What do you mean by ITP? What do you mean by ITP? ITP means immune thrombocytopenic purpura. Immune thrombocytopenic purpura. এই যে পারপিউরা, পেটিচিয়াল একাইনোমোসিস বলছি, এগুলো কি জিনিস জানিস? র্যাস, how can you differentiate? This is a purpura, this is a chymosis, this is a petechial. That is important. You have to tell your seniors or your resident or your consultant that this is some petechial rash is there. Petechial rash is significant clinically. It may cause any disease. That may be dengue, that may be ITP, that may be bleeding disorder. So remember, petechial rash means the size. Here size is a important factor. What are those? Petechials means 1 to 2 millimeter size of rash. It is a petechial rash. It is a petechial rash. And then the purpura. Purpura থেকে একটু বড়, ওর থেকে 0.3 সেন্টিমিটার to 1 সেন্টিমিটার, বোঝা যাচ্ছে? And then the ecchymosis. একাইমোসিসটা বড়, একাইমোসিস হচ্ছে more than 1 centimeter. Finish. খুব কঠিন নয়. So if any thinking that the heavy area is going on, that is ecchymosis or easy bruising. Another term is a bruising. Bruising is huge. একটা পুরো একটা হাত আছে, হাতে এতটা জায়গা একটা কালো দাগ, বা ইউ ক্যান মেক কমপ্লেন অ্যাবাউট দ্যাট আমি ঠুকে দিলেই আমার ওখানে কালো দাগ হয়ে যায়। অ্যালার্ট। So these things are happening. Petechial rash, purpura rash, ecchymosis is about the nothing else piece. It's not your just for your thoughts that the sir is telling that the petechial rash. These are the commonly seen. Both basically primary two is from, it is seen as a platelet plaque formations problem. That means mostly the bleeding disorder and the bleeding time will be high, no the APTT or anything else high. But in case of ecchymosis, that means deep breathing must be there. And remember always, coagulation cascade remains as like the hemophilia. Remember, because hemophilia is a factor, hemophilia A is a factor 8, then factor 9, all are in the coagulation cascade. So that presents in the joint pain and joint swelling and joint bleeding. and muscle bleeding also. That is dangerous. It may cause any deep organ bleeding also. But in case of primary plaque formations problem, there must be some superficial bleeding like epistaxis, like a petechial rash, is a purpuric rash, and then also epistaxis, menorrhagia, etc. So many patients will come with like that, and that may transform into the coagulation cascade problem or at all. So we test কি দিই আমরা দিতে পারি বিটি, আমরা দিতে পারি সিটি, আমরা দিতে পারি এপিটিটি, এগুলো আগের দিন বলেছিলাম, টিটি thrombosis passing time, and then also the PT, and then also INR. So liver disease, as well as you are thinking for the coagulation cascade problem or bleeding problems, etc. Now this intrinsic pathway, why? Intrinsic pathway, and this is the right arm and the left arm of this Y. This is a process of this class. Intrinsic, extrinsic, common pathway. Whenever there is a problem of this intrinsic pathway, mostly these tests will be higher. Intrinsic pathway, this is the most important pathway. And this is the extrinsic pathway, that is the TTP and the PT also this. And intrinsic pathway as well as INR, international standardized ratio, INR, PT, INR is coming as a whole, as a controller. It's not so much important in this stage of your class, but still remember that whenever you are dealing with a case presentations or may come in your exam, they এরকম একটা পেশেন্ট আছে 56-year-old male patient having a joint swelling is there, joint pain is there, his APTT is high. So you already concentrate into the intrinsic factor. So now you are thinking that this may be the hemophilia. So what is your diagnosis? How can you explain this and explain the coagulation cascade? In this way your exam is coming. Last 10 years এ যেভাবে কোশ্চেন এসছে এখন থেকে সব করতে আরম্ভ কর, একটা চ্যাপ্টার শেষ হবে করতে থাকবি, বোঝা যাচ্ছে? খাটতে হবে একটু, it will pass, no problem. Target is 50%, not at all 60%. But if it's 50%, that is strictly 60, that is, if it is 50% target, that means 50% must be there. If you 50 তো হয়ে যাবে, no, not at all. Then it will come at 30%. 50 means 50, not 49. 50 means 50. Okay, thank you very much.
What is nucleoside? Nucleotide. And polynucleotides means nucleic acids. Polypeptides means protein. Polynucleotides means nucleic acids. DNA and RNA, both are nucleic acid. When there is a deoxyribose, that is DNA. When there is ribose, that is RNA. There are also other differences between the RNA and DNA. সেটা পরে হবে। এখন আমি যেটা বলতে চাইছি, আসলে আমরা ডিএনএ এবং আরএনএ পড়ানোর জন্যই আমরা নিউক্লিওটাইডটা পড়াই, আর নিউক্লিওটাইড পড়ানোর জন্যই আমরা বেস নিউক্লিওসাইডটা পড়াই। হ্যাঁ, আমি যদি বেস বলি, কত রকম বেস আছে তোমরা নিশ্চয়ই পড়েছো। আই এম জাস্ট রিক্যাপিচুলেটিং। বেস, nucleoside, nucleotide. There are three terminology. Base means nitrogenous base. সেখানে নাইট্রোজেন থাকবেই থাকবে। তাহলে কি কি বেস আছে? Purine, small name but large structure. Large name but small structure. Okay? পিউরিনে দুটো রিং থাকে, পিরিমিডিনে একটা রিং থাকে। পিউরিনে 4টে নাইট্রোজেন থাকে, পিরিমিডিনে দুটো নাইট্রোজেন থাকে। পিউরিন স্মল নেম, লার্জার স্ট্রাকচার। পিরিমিডিন লার্জ নেম, স্মলার স্ট্রাকচার। পিউরিন বেস যদি কি হতে পারে? অ্যাডিনিন, গুয়ানিন। আর কি হতে পারে? কিন্তু এই দুটো থাকে ডিএনএতে, ডিএনএ বা আরএনএতে এগুলো থাকে। These are called atypical base. Atypical means not typical, not present in RNA DNA. সেই জন্য এটাকে atypical base বলে। হ্যাঁ, typical base means those who are present in DNA or RNA. Atypical base means these are present in other compounds other than RNA or DNA. আমি জাস্ট পিউরিন যদি অ্যাডেনিন যদি ইয়ে হয়, হোয়াট ইজ দ্য নিউক্লিওসাইড? নিউক্লিওসাইডের নাম হবে অ্যাডেনোসিন। গুয়ানিন যদি হয় গুয়ানোসিন। These are nucleoside. That means base plus sugar. Sugar means ribose or deoxyribose. When adenine is base, adenosine is the nucleoside. When guanine is base, guanosine is the nucleoside. And when adenosine is nucleoside, nucleotide will be AMP, adenosine monophosphate, GMP. তাহলে নিউক্লিওসাইড হচ্ছে অ্যাডেনিন, বেস হচ্ছে কি অ্যাডেনিন, নিউক্লিওসাইড হচ্ছে অ্যাডেনোসিন, নিউক্লিওটাইড হচ্ছে কি অ্যাডেনোসিন মনোফসফেট অর অ্যাডেনাইলেট, এটাকে তুমি অ্যাডেনাইলেট বলতে পারো, অ্যাডেনাইলিক অ্যাসিড বলতে পারো। এইটাকে বলছে গুয়ানাইলেট। অ্যাটিপিক্যাল বেস যখন হাইপোজান্থিন হবে তখন কি হবে? বেস হচ্ছে গিয়ে আইনোসিন, নিউক্লিওটাইড হবে আইএমপি, আইনোসিন মনোফসফেট। জ্যান্থিন যখন বেস হবে তখন নিউক্লিওটাইড হবে জ্যান্থিন প্লাস রাইবোজ ইজিক্যাল টু জ্যান্থোসিন। Corresponding nucleotide is the xanthosine monophosphate. ক্লিন কাট আইডিয়া থাকতে হবে একদম। অনেক সময় আমরা জিজ্ঞেস করি আইএমপি, আইএমপি is the first nucleotide that is formed in our body. First purine nucleotide is formed in our body. IMP. What is the base of the IMP? Question is, what is the base of the IMP? Then it is answer will be hypoxanthine. Okay, base of the inosine, the base of the IMP or base of the inosine. What answer is the hypoxanthine. Xanthine যদি বেস হয়, xanthosine হবে, xanthosine monophosphate হবে. These are not present in the RNA or DNA. So these are called atypical base. Pyrimidine কি থাকছে? pyrimidine কি কি থাকছে? সাইটোসিন আর সাইটোসিন কি থাকে বলো? ইউরাসিল। এইটাই কোশ্চেনটা করে। এখন তোমরা পড়ছো থাইমিন, এখন তোমাদের আরএনএ স্ট্রাকচার হয়নি, যতক্ষণ না আরএনএ স্ট্রাকচার হয়নি ততক্ষণ তোমরা বলবে থাইমিন ডিএনএতেই থাকে, আরএনএতে থাকে না। কিন্তু যখন আরএনএ এর ক্লাসিফিকেশন করবে, হ্যাঁ, তখন দেখবে পার্টিকুলার টাইপ অফ দ্য আরএনএ আছে একটা যেখানে কিন্তু থাইমিন থাকে, আমি কিন্তু ইউজুয়ালি তোমরা জিজ্ঞেস করলে থাইমিন ডিএনএ থাকে না আরএনএ থাকে, ইউর অ্যান্সার শুড বি ইট শুড বি প্রেজেন্ট ইন দ্য ডিএনএ। হ্যাঁ হ্যাঁ, তুমি যদি প্রথমে আরএনএতে বলো তাহলে তোমাকে আর প্রশ্ন জিজ্ঞেস করবে না, তুমি যদি বলো ডিএনএতে তখন তোমাকে প্রশ্ন জিজ্ঞেস করবে আচ্ছা থেকে আরএনএটা থাকতে পারে। নেক্সট কোশ্চেন, সাইটোসিন যদি হয় হ্যাঁ তাহলে কি হবে, বেস কি হবে, নিউক্লিওসাইড কি হবে বলো? সাইটিডিন, প্রত্যেকটা টার্মিনোলজি এবং স্পেলিং মনে রাখবে। সাইটোসিন, সাইটিডিন, নিউক্লিওসাইড। আর সাইটোসিন মনোফসফেট और সাইটিডাইলেট, এর নাম হচ্ছে গিয়ে সাইটিডাইলেট আর সাইটিডাইলিক অ্যাসিড। This is nucleotide, base sugar phosphate. These are nucleotide. ইউরাসিল যদি হয় তখন কি বলছে? ইউরিডিন। And the corresponding nucleotide will be UMP. থাইমিন যদি হয় থাইমিডিন। থাইমিডিন মনোফসফেট, থাইমিন মনোফসফেট। এবার প্রত্যেকটা কিন্তু ডি ডি দিয়ে হয়। এটা ডিঅ্যাডিনোসিন হতে পারে, এটাও কিন্তু এখানে সুগারটা হবে ডিঅক্সিরাইবোজ। ডিঅ্যাডেনোসিন মানে সুগার হচ্ছে ডিঅক্সিরাইবোজ, অ্যাডেনোসিন মানে সুগার হচ্ছে রাইবোজ। আবার এখানেও ডি গুয়ানোসিন হতে পারে। আমরা এখানে বলছি না কারণ এটা ডিএনএতে আপনাদের থাকে না, এখানে যদি থাকে সেটা হচ্ছে শুধু রাইবোজ সুগারই থাকে, কোনো ডিঅক্সিরাইবোজ কিন্তু এখানে থাকে না। আইনোসিন এবং জান্থোসিনে সবসময় রাইবোজ সুগার থাকে। সাইটিডিনে থাকতে পারে ডিঅক্সিরাইবোজ, তখন ওর নাম হবে সিডি সাইটিডিন। ইউরিডিনে থাকবে তখন থাকবে আমরা ডি ইউরিডিন। থাইমিনে আমি ডি থাইমিডিন বলতেও পারি নাও বলতে পারি, ডি কথাটা আমি লিখতেও পারি নাও লিখতে পারি। আমি ডি না লিখলেও থাইমিডিন মানে ডিঅক্সিরাইবোজ সুগার। আমি যদি ডি মেনশন নাও করি, থাইমিডিন কথাটার মানে হচ্ছে থাইমিন প্লাস ডিঅক্সিরাইবোজ। সো আমার ডি লেখা আর না লেখার মধ্যে খুব একটা তফাৎ নেই ইন কেস অফ থাইমিডিন, কিন্তু অন্যদের তফাৎ আছে ডি লেখা না লেখার মধ্যে। থাইমিডিনের ক্ষেত্রে আমি ডি লিখলেই বা কি না লিখলেই বা কি, তার কারণ থাইমিডিনের সুগার ইজ অলওয়েজ ডিঅক্সিরাইবোজ। থাইমিডিনের সুগার ইজ অলওয়েজ ডিঅক্সিরাইবোজ। এবং এখানেও তাই, এখানেও আমরা ডিএমপি লিখতে পারি, ডিএমপি হতে পারে, ডিজিএমপি হতে পারে, যেখানে সুগারটা এখানে ডিসিএমপি হতে পারে। ইউরাসিল থাকে ডিএনএতে, থাকে না, সেই জন্য ডিইউএমপি কথাটা এখানে শুধুমাত্র ইউএমপি। হ্যাঁ, এক্ষেত্রে আমি ডিটিএমপি আর টিএমপি কথাটা মানে কিন্তু একই। টিএমপি আর ডিটিএমপির মানে কথাটার মানে কিন্তু একই, বুঝতে পেরেছ? যেহেতু থাইমিডিন ইজ এ প্রেজেন্ট ইজ এ ডিএনএ and DNA contains deoxyribose, so thymidine মানে হচ্ছে গিয়ে deoxyribose plus thymine। এই কথাগুলো প্রত্যেকটা টার্মিনোলজি রিগার্ডিং বেস, করসপন্ডিং নিউক্লিওসাইড অ্যান্ড নিউক্লিওটাইডস একদম পরিষ্কার থাকতে হবে জলের বোতল, বিকজ নিউক্লিওটাইড যখন আমরা করব, নিউক্লিওটাইডের পলিমার যখন আমরা করব, দ্যাট ইজ দ্য জেনেটিক ম্যাটেরিয়াল DNA and RNA. Polymer of the nucleotide is the polynucleotides. Polynucleotides means nucleic acids. Nucleic acids are of the two types, DNA and RNA. It is a basic conception of the nucleotide. Basic conception of the nucleotide. এটা তোমার পড়ো, আজকে ক্লাস হয়েছে। অ্যাটিপিক্যাল বেসগুলো পড়বে, নিউক্লিওটাইড অ্যানালগ আছে সেগুলো পড়বে। নিউক্লিওটাইড অ্যানালগ কাকে বলে? নিউক্লিওটাইড অ্যানালগ ইজ এ ভেরি ইম্পর্ট্যান্ট ড্রাগ ফর অ্যান্টি ক্যান্সারাস এজেন্টস। ট্রিটমেন্ট অফ দ্য ক্যান্সারের জন্য যেটা আমরা ড্রাগ ইউজ করি, দ্যাট ইজ সিমিলার টু নিউক্লিওটাইড বাট নট দ্য নিউক্লিওটাইড। Similar to nucleotide but not the nucleotide, that is called nucleotide analog, that is used in treatment of the cancer, treatment of the some treatment of the hyperuricemia to use kora hoy. Allopurinol is also a atypical nucleotide that is used in the treatment of gout. Other than allopurinol, all other nucleotide analogs are anti-cancerous agents. Anyway, this is আমি বললাম না নাটসেলে নিউক্লিওটাইডস। কিন্তু আমি আজকে যেটা আমি রিক্যাপিচুলেট করব, যেটা হচ্ছে গিয়ে কেমিস্ট্রি অফ দ্য লিপিডস। কি পড়েছো তোমরা? লিপিডসের কেমিস্ট্রি। হোয়াট হ্যাভ ইউ রেড? কেমিস্ট্রি অফ দ্য লিপিডস। লিপিডসের ডেফিনেশন বলো, বলো তো। হোয়াট ইজ দ্য হাউ ডু ইউ ডিফাইন লিপিড? যদি কিছু মনে থাকে। তুমি লিপিডের ডেসক্রিপশন দিচ্ছ। Yes, it is a description of the lipid, of course. But by definition, lipid is na. Yes, it is a heterogeneous compounds insoluble in polar solvent like water, and soluble in non-polar solvents like ether, chloroform, benzene, alcohol. লিপিডসের কোনো ডেফিনিট ক্লাসিফিকেশন বা যে ক্লাসিফিকেশনটা দিয়ে মোটামুটি একটা ইয়ে করা যেতে পারে, যেমন পলিহাইড্রক্সি অ্যালডিহাইড বা পলিমার অফ দ্য অ্যামাইনো অ্যাসিড প্রোটিনের ক্ষেত্রে, লিপিডের ক্ষেত্রে কিন্তু এইরকম ডেফিনেশন দেওয়া যায়নি। এইরকম ডেফিনেশন দেওয়া যায়নি, কারণ যাই আমি ডিফাইন করি কেমিক্যালি, সেই ডেফিনেশনে কিন্তু সমস্ত লিপিডকে ইনক্লুড করবে না। সমস্ত লিপিডকে ইনক্লুড করতে গেলে যে ডেফিনেশন আমরা ব্যবহার করেছি, সেই ডেফিনেশনটা খুব সহজ ডেফিনেশন, যাতে করে সমস্ত লিপিডকে ইনক্লুড করতে পারি। সেই ডেফিনেশনটা হলো দ্য হেটারোজেনাস সাবস্টেন্সেস soluble in non-polar solvents but insoluble in polar solvents. These are the universal definition of the lipids. এবার তুমি বলতে পারো ester of the fatty acid alcohol, that is a definition of the particular lipid, not all lipids. That will include particular lipids. পার্টিকুলার লিপিড তুমি ডেসক্রাইব করতে পারো অনেকভাবে, কিন্তু লিপিডের ডেফিনেশন কিন্তু এটাই হবে। ক্লাসিফিকেশন, ঠিক আছে। সিম্পল কাকে বলে? সিম্পল লিপিড হচ্ছে এস্টার অফ ফ্যাটি অ্যাসিড অ্যান্ড alcohol. When alcohol may be glycerol, may be non-glycerol. Ester of fatty acid and alcohol. This is the simple lipid. ফ্যাটি অ্যাসিড যদি অ্যালকোহল যখন গ্লিসারল হবে তখন তাকে আমরা বলবো ফ্যাট। আর ফ্যাটি অ্যাসিড অ্যালকোহল যখন হায়ার মলিকুলার ওয়েট অ্যালকোহল হবে তখন তাকে আমরা বলবো ওয়াক্স। We are not concerned with wax. Wax is not present inside our body. It may be present in the earwax, cerumen, but otherwise it is not present inside the body. আমরা ওয়াক্স মেটাবলিজম আমরা জানি না, ওয়াক্স মেটাবলিজম আমরা পড়ি না, জানি না মানে কি আমরা পড়ি না। আমরা যেটা পড়ি ফ্যাট মেটাবলিজম। সিম্পল লিপিড কাকে বলছে? এস্টার অফ ফ্যাটি অ্যাসিড অ্যান্ড অ্যালকোহল। অ্যালকোহল যদি গ্লিসারল হয়, অ্যালকোহল হায়ার মনোহাইড্রিক অ্যালকোহল। মনোহাইড্রিক মানে একটাই ওইচ গ্রুপ আছে, হতে পারে যখন এস্টার যখন ফ্যাটি অ্যাসিড এবং গ্লিসারল যখন হবে তখন সেটাকে বলবো আমরা ফ্যাট, এটাকে বলবো আমরা ওয়াক্স। We are concerned with fat. We are concerned mainly with fat. Much more concerned. Fat is the glycerol plus fatty acid. Smaller portion is the glycerol, but larger portion is the fatty acid. Properties of the fat, nature of the fat, function of the fat, all are determined by the fatty acid content, not the glycerol content. So fatty acid is the major part of the fat. So you are concerned with fatty acids. Concern of the fatty acid means concern of the fat. We are concerned with fatty acids, that is, we are concerned with fat. একটা ফ্যাট কিরকম হবে, সেটা খারাপ ফ্যাট না ভালো ফ্যাট, তার কি প্রপার্টি, তার কি ফাংশন, that is solely determined by its fatty acid content. ঠিক আছে, গ্লিসারল কন্টেন্টের উপর খুব একটা ডিপেন্ড করে না। গ্লিসারল হচ্ছে একটা অ্যালকোহল যার তিনটে ওইচ গ্রুপ আছে এবং তিনটে ওইচ গ্রুপ ইজ লিঙ্কড টু তিনটে ফ্যাটি অ্যাসিড। সো ফ্যাট ইজ নোন অ্যাজ, কেমিক্যালি ফ্যাট ইজ নোন অ্যাজ ট্রাই অ্যাসাইল গ্লিসারল। কেমিক্যালি ফ্যাট ইজ নোন অ্যাজ ট্রাই অ্যাসাইল glycerol or dry glycerides. তাহলে হোয়াট ইজ দ্যাট ইজ, যেটা যাকেই আমরা ট্রাইগ্লিসারাইড বলছি তাকেই আমরা বলছি ট্রাইঅ্যাসাইল গ্লিসারল, তাকেই আমরা বলছি ফ্যাট। তাহলে হোয়াট ইজ ওয়েলস, হোয়াট ইজ দ্য ডিফারেন্স বিটুইন দ্য ফ্যাটস অ্যান্ড ওয়েলস? Fats and oils are similar in structure and similar in function. that is ester of fatty acid and alcohol. Only difference is in the melting point. When it is liquid at room temperature, it is called oil. When it is semi-solid or solid at room temperature, it will be called fat. There is no other difference between fats and oils other than melting points, other than it is oil, oil is liquid, fat is solid. Only difference. তাহলে ফ্যাট অ্যান্ড অয়েল কিন্তু একই। আর ফ্যাট মানে হচ্ছে এস্টার অফ ফ্যাটি অ্যাসিড অ্যান্ড গ্লিসারল। তাহলে গ্লিসারলটা কি? CH2OH, CHOH, CH2OH। ঠিক আছে, এবার প্রত্যেকের সঙ্গে যদি আমি ফ্যাটি অ্যাসিড যদি আমি লাগাই তাহলে এস্টার হবে। এস্টার মানে কি? অ্যাসিড এবং অ্যালকোহল। অ্যাসিড এবং অ্যালকোহল থাকে তো, অ্যাসিড এবং অ্যালকোহলের মধ্যে একটা কম্বিনেশন হয় এবং একটা মলিকুল অফ ওয়াটার বেরিয়ে যায়, তাহলে যে লিঙ্কেজ তৈরি হয় সেটাকে বলছি এস্টার লিঙ্কেজ। তাহলে কি হবে? প্রত্যেকটা জায়গা থেকে এখান থেকে OH আর এখান থেকে H বেরিয়ে গেল, OH এখান থেকে H বেরিয়ে গেল। তাহলে স্ট্রাকচারটা কি দাঁড়াচ্ছে? এটা ও হবে। অ্যাকচুয়ালি এইভাবে থাকে কিন্তু বডিতে, কারণ এখানে থাকলে কাছাকাছি হয়ে যাবে, একটা স্টেরিক হিন্ড্রেন্স ডেভেলপ করে, সেই জন্য স্ট্রাকচারের কিন্তু এইভাবেই থাকে। R1, R2, R3, it may be saturated, it may be unsaturated. যদি স্টিয়ারিক অ্যাসিড হয় তিনটেই, তখন তার নাম হবে ট্রাই স্টিয়ারিন। তিনটেই যদি পামিটিক অ্যাসিড হয় তার নাম হবে ট্রাইপামিটিন। তিনটেই যদি অলিক অ্যাসিড হয় সেটার নাম হবে ট্রাইঅলিন। হুইচ ফ্যাটি অ্যাসিড ইজ দ্য মোস্ট অ্যাবান্ডেন্ট? আমাদের বডিতে যে ফ্যাটি অ্যাসিড থাকে তার মধ্যে হচ্ছে গিয়ে স্টিয়ারিক অ্যাসিড, পামিটিক অ্যাসিড, অলিক অ্যাসিড। এই তিনটে ফ্যাটি অ্যাসিড খুব কমন। তার মধ্যে মোস্ট অ্যাবান্ডেন্ট ফ্যাটি অ্যাসিড ইজ দ্য অলিক অ্যাসিড। যদি বলা হয় সবচেয়ে কমন স্যাচুরেটেড ফ্যাটি অ্যাসিড কোনটা, তখন হবে পামিটিক অ্যাসিড। সবচেয়ে কমন আনস্যাচুরেটেড ফ্যাটি অ্যাসিড কোনটা? অ্যান্সার হবে অলিক অ্যাসিড। তাহলে ফ্যাট, দিস ইজ দ্য স্ট্রাকচার অফ দ্য ট্রাইঅ্যাসিল গ্লিসারল or triglyceride. What is the importance of the triglyceride? What is the importance of the triglyceride? We are concerned with triglyceride. We are concerned mainly with two lipids. Clinicians are concerned mainly with two lipids. One is triglyceride, another is cholesterol. Why we are concerned with triglyceride? Why we are concerned with triglyceride? Because triglyceride is the storage fat, storage lipid. আমার দরকার আমি 2000 ক্যালোরি ডে টু ডে অ্যাক্টিভিটির জন্য, আমি খেলাম 3000 ক্যালোরি, বাকি 1000 ক্যালোরি কি হবে? কিছুটা গ্লাইকোজেন হিসেবে স্টোর হবে, বাকিটা 300 থেকে 400 গ্রাম গ্লাইকোজেন হিসেবে স্টোর হবে মিলিগ্রাম, আর বাকিটা স্টোর হবে ট্রাইঅ্যাসাইল গ্লিসারল রূপে, এবং সেটা সাবকিউটেনিয়াস ফ্যাটে জমবে, ভিসারাল অর্গানে টিস্যুতে জমবে। ভিসারাল ফ্যাট ইজ মাচ মোর ডেঞ্জারাস দেন সাবকিউটেনিয়াস ফ্যাট। সাবকিউটেনিয়াস ফ্যাটের থেকে ভিসারাল ফ্যাট ইজ মাচ মোর ডেঞ্জারাস। অনেক লিন অ্যান্ড থিন পার্সন আছে, কিন্তু তাদের ভিসারাল ফ্যাট অনেক বেশি। দে আর মাচ মোর প্রোন টু করোনারি আর্টারি ডিজিজ, much more prone. Triacylglycerol is the storage, এটার জন্য ডিপেন্ড করে, এর উপর ডিপেন্ড করে আছে ওবেসিটি। Obesity is due to excessive accumulation of the triacylglycerol either in the subcutaneous tissue or in the viscera. Obesity is the accumulation of the ট্রাইগ্লিসারাইড ইন দ্য বডি। যদি কিছু না লিখতে পারো কোথায়? and obesity is linked to many diseases, and first and foremost we are concerned with obesity. why? obesity জন্য ওজন বাড়বে, তো ক্ষতি কি? ওজন বাড়ুক না, আমাদের কি ক্ষতি? Because obesity predisposes to some diseases, and first and foremost diseases, diabetes mellitus. Obesity is related to diabetes mellitus, and cholesterol is related to atherosclerosis. Cholesterol is related to atherosclerosis and coronary artery disease. Triglyceride is related to obesity, and obesity leads to many diseases like diabetes mellitus. Obesity is indirectly related to coronary artery disease, not directly. Obesity is indirectly related to coronary artery disease. Hypercholesterolemia is directly related to coronary artery disease. ঠিক আছে, এইবারে বলো, আমি এতক্ষণ ধরে ফ্যাট নিয়ে বলছিলাম, এবারে ফ্যাটের মেজর পোর্শনটা কি, যার উপর ফ্যাটের নেচার, ফ্যাটের কোয়ালিটি, ফ্যাটের ফাংশন ডিপেন্ড করছে, দ্যাট ইজ ফ্যাটি অ্যাসিড। হাউ ডু ইউ ক্লাসিফাই ফ্যাটি অ্যাসিড? কত রকম ভাবে ক্লাসিফাই করা যায় বলো? ইয়েস, কমন ক্লাসিফিকেশন ইজ দ্য স্যাচুরেটেড, আনস্যাচুরেটেড, and unsaturated is the again subclassified into monounsaturated and polyunsaturated. This is the unique classification. Any other mode of classification? Chain, length এর উপর, long chain fatty acid, medium chain fatty acid, short chain fatty acid, আর long chain এর পরে আবার very long chain fatty acid বলছে। As per length of the chain, as per degree of the saturation করতে পারি। আর একটা কি ক্লাসিফিকেশন আছে? on the basis of number of carbon, কিরকম? odd chain fat, even chain, odd chain, even chain। আমাদের বডিতে কোনটা আছে, odd chain না even chain আছে? which chain is predominant, even chain or odd? even chain, yes. What are the even chain fatty acids? Palmitic acid, কত কার্বন? 16। স্টিয়ারিক অ্যাসিড কত কার্বন? 18। বোথ আর স্যাচুরেটেড, দেয়ার ইজ নো ডবল বন্ড। ডবল বন্ড কোথায় আছে? কোন ফ্যাটি অ্যাসিডের ডবল বন্ড আছে? মোস্ট কমন ফ্যাটি অ্যাসিড, মোস্ট অ্যাবান্ডেন্ট ফ্যাটি অ্যাসিড, দ্যাট ইজ অলিক অ্যাসিড। অলিক অ্যাসিডের ডবল বন্ড আছে। কটা ডবল বন্ড আছে? কটা ডবল বন্ড আছে? একটা। তাহলে অলিক অ্যাসিড ইজ দ্য মনো আনস্যাচুরেটেড ফ্যাটি অ্যাসিড, মুফা। অলিক অ্যাসিড হচ্ছে গিয়ে মুফা। আমি কিন্তু এগুলো সব পড়িয়েছি আগে, আমি রিক্যাপিচুলেট করছি। মুফা ইজ অলিক অ্যাসিড। এবারে এসো কুফা। বলো কুফার এক্সাম্পল দাও। কে বলছে? তুমি বলো, তুমি একটা এক্সাম্পল দাও। অ্যারাকিডোনিক অ্যাসিড। এবার এক এক করে বলো তো দেখি। একটা কার্বন, দুটো কার্বন, দুটো ডবল বন্ড, তিনটে ডবল বন্ড, চারটে ডবল বন্ড, পাঁচটা ডবল বন্ড, ছটা ডবল বন্ড আমি পড়িয়েছি। একটা ডবল বন্ড হচ্ছে অলিক অ্যাসিড। একটা ডবল বন্ড অলিক অ্যাসিড। বলো একটা ডবল বন্ড হচ্ছে গিয়ে ওয়ানের এক্সাম্পল হচ্ছে অলিক অ্যাসিড। আর যদি আরো বলতে পারো পামিটোলিক অ্যাসিড। অলিক অ্যাসিড এন্ড পামিটোলিক অ্যাসিডের মধ্যে তফাৎ কি? চেন লেন্থ। এখানে 18 কার্বন, এখানে 16 কার্বন। এখানে 18 কার্বন এবং 16 কার্বন। এবার বলতো অলিক অ্যাসিডের যদি বলি আমরা পজিশন অফ দ্য ডবল বন্ড, পজিশন অফ দ্য ডবল বন্ড 9, 10। এবং অলিক অ্যাসিডকে আমরা অ্যাব্রিভিয়েটেড ফর্মে কি লিখি? ওমেগা। ডেল ডেল কত বলবো আগে? নাম্বার অফ ডেল 18। সেমিকলন দিতে হবে, সেমিকলন, তারপরে পজিশন অফ দ্য ডবল বন্ড। 9 মানে কি? 9, 10 ডবল বন্ড। 12 মানে 12, 13। 15 মানে 15, 16। তাহলে এটার 9 হলো। এটার কি হবে? এটার হবে 16 হবে, এটারও কিন্তু 9। দুটো ডবল বন্ড নাম বলো, দুটো ডবল বন্ডের এক্সাম্পল দাও। লিনোলিক, ঠিক আছে। লিনোলিকের কটা কার্বন? 18 কার্বন। কটা ডবল বন্ড? 9, 12। তার মানে 9, 10, 12, 13। কোন দিক থেকে ধরবো? একটা হচ্ছে মিথাইলেন আর একটা হচ্ছে কার্বক্সিলিক অ্যাসিড। আমরা এই দিক থেকে ধরছি, এই দিক থেকে ধরছি, তখন তার নাম হচ্ছে ডেল্টা। আর যদি এদিক থেকে ধরি তার নাম হবে ওমেগা। ওমেগা 3 মানে there is a double bond between omega 3 and omega 4. That means এখান থেকে ওমেগা 3 মানে ওমেগা, এটা হচ্ছে 1 নম্বর, তারপরে 2 নম্বর, তারপরে 3 নম্বর, CH2 CH। এইরকম যদি ফ্যাটি অ্যাসিড থাকে 3 এবং 4, 3 এবং 4 যদি ডবল বন্ড থাকে, counting from methylene, that fatty acid is called omega 3 fatty acid. আবার এদিক থেকে যদি 6 আর 7 যদি থাকে ডবল বন্ড, তাহলে ওমেগা 6। আর এদিক থেকে যদি 9 আর 10 যদি থাকে, সেটা হচ্ছে ওমেগা 9। ইন কেস অফ অলিক অ্যাসিড ইট ইজ ডেল 9 অ্যাজ ওয়েল অ্যাজ ওমেগা 9। তুমি যেদিক থেকেই কাউন্ট করো 9, 10 হবে। অলিক অ্যাসিডের তুমি যেদিক থেকেই কাউন্ট করো না কেন, এই দিক কার্বক্সিলেট গ্রুপ থেকেই কাউন্ট করো আর মিথাইল এর থেকেই কাউন্ট করো না কেন, পজিশন অফ দ্য ডবল বন্ড উইল বি 9-10। সেই জন্য ওইটাকে ওমেগা 9 ফ্যাটি অ্যাসিডও বলা যেতে পারে। ওমেগা 3, ওমেগা 6, ওমেগা 9, হুইচ ওয়ান ইজ দ্য মোস্ট ইম্পর্টেন্ট? হুইচ ওয়ান ইজ দ্য মোস্ট ইম্পর্টেন্ট? কোনটা খেতে বলছি আমরা বেশি করে? ওমেগা 3। ওমেগা 3, ওমেগা 3টা কোথায় থাকে? ফিশ অয়েলে থাকে। ভেরি গুড। পার্টিকুলারলি সি ফিশ, স্যালমন, টুনা, ম্যাকারল, কড লিভার, আমাদের ইলিশ মাছেও থাকে, কারণ ইলিশ মাছ প্র্যাকটিক্যালি সি ফিশ। সমস্ত সি ফিশে থাকবে ওমেগা 3 ফ্যাটি অ্যাসিড, সমস্ত সি ফিশে থাকবে ওমেগা 3 ফ্যাটি অ্যাসিড। সেই জন্য আমরা সি ফিশ ইজ ভেরি বেনিফিশিয়াল টু হার্ট, ইট প্রিভেন্টস করোনারি আর্টারি ডিজিজ। ওমেগা 3 ফ্যাটি অ্যাসিড, ওমেগা 6 ফ্যাটি অ্যাসিড, ওমেগা 9 ফ্যাটি অ্যাসিড, তার মধ্যে ওমেগা 3 ইট ইজ হ্যাজ বিন ফাউন্ড ওমেগা 3 ফ্যাটি অ্যাসিড ইজ ভেরি মাচ linked to coronary artery disease regarding prevention. তাহলে লিনোলিকটা কি হবে? ওমেগা 6 না ওমেগা 3 হবে? লিনোলিকটা কি? ওমেগা 6, এটা ওমেগা 6। তিনটে ডবল বন্ড বলো, নাম বলো। লিনিক, লিনোলিনিক কি হবে? এটা 18 কার্বন, 9, 12, 15। তাহলে এটা কি ওমেগা 3 হবে না ওমেগা 6 হবে? কি করে কাউন্ট করে বলো তো দেখি। এই দেখো, এই 18কে 15 দিয়ে বাদ দাও, এখানে 18কে 12 দিয়ে বাদ দাও, তাহলে 6 হচ্ছে। এখানে 18কে যদি 15 দিয়ে আমি বাদ দিই তাহলে 3 হচ্ছে, তাহলে এটা ওমেগা 3 হবে। কিন্তু লিনোলিক হবে ওমেগা 6, লিনোলিক হবে ওমেগা 6। 3 নম্বর হলো। 4 নম্বর ইজ ভেরি কমন ফ্যাটি অ্যাসিড। Why it is very important? Arachidonic acid is very important for কিসের জন্য arachidonic acid ইম্পর্টেন্ট? ইকোসায়ানয়েডস, 20 কার্বন মানে ইকোসায়ানোয়িক অ্যাসিড। ইকোসা মানে 20 কার্বন। টার্ম ইকোসা means it is 20 কার্বন ডেরিভেটিভ। অ্যারাকিডোনিক অ্যাসিডে 20 কার্বন থাকছে, এবং অ্যারাকিডোনিক অ্যাসিড থেকে যে জিনিস তৈরি হচ্ছে নানা দুটো পাথওয়েতে পড়িয়েছি আমি, সাইক্লোঅক্সিজেনাস পাথওয়ে আর একটা লাইপোঅক্সিজেনাস পাথওয়ে। এই দুটো পাথওয়েতে যে জিনিস তৈরি হয় স্টার্টিং ফ্রম অ্যারাকিডোনিক অ্যাসিড তাকে বলা হচ্ছে আইকোসায়ানয়েডস। তাহলে 3টে হচ্ছে লিনোলিনিক অ্যাসিড, 4টে হচ্ছে গিয়ে অ্যারাকিডোনিক। অ্যারাকিডোনিকের এটা কি হবে? অ্যাব্রিভিয়েশনটা হবে ডেল 20, 5, 8, 11, 14। এবার 20 - 14 মানে 6, তাহলে এটা ওমেগা 6 হবে। তাহলে এটা ওমেগা 6 হবে। তাহলে কোনটা ওমেগা 3, ওমেগা 6, ওমেগা 9 এটা কিন্তু আইডিয়াটা থাকতে হবে। 5 যদি হয় ফ্যাটি অ্যাসিড তাহলে কি বলে? 5টা ডবল বন্ড, আইকোসা পেন্টিয়ানোয়িক অ্যাসিড, ইপিএ। এর একটা পোশাকি নাম হচ্ছে গিয়ে, এই যেমন অ্যারাকিডোনিক, এর পোশাকি নাম হচ্ছে গিয়ে টিমনোডোনিক। Quinodonic acid is 5 কার্ব 5টা ডবল বন্ড আছে। কি কি পজিশন? ইকোসা মানে 20, ইকোসা মানে 20, সেখানে জানবে 20টা কার্বন আছে। ইকোসানোয়েটস 20টা কার্বন থাকবে। ইকোসা পেন্টানোইক অ্যাসিড তার মানে 20 কার্বন, আনস্যাচুরেটেড ফ্যাটি অ্যাসিড হ্যাভিং 5 ডাবল বন্ডস। 20 কার্বন আনস্যাচুরেটেড ফ্যাটি অ্যাসিড, পলিআনস্যাচুরেটেড ফ্যাটি অ্যাসিড হ্যাভিং 5 ডাবল বন্ডস। ইম্পর্টেন্ট এক্সাম্পল হচ্ছে গিয়ে ইপিএ, ইকোসা পেন্টানোইক অ্যাসিড। এবং এর ডবল বন্ডের ক্যারেক্টারিস্টিক কি হবে? 5, 8, ওই 11, 14 তো, আর একটা 3 যোগ করে দাও, 17। এবার বলো এটা ওমেগা 3 হবে না ওমেগা 6 হবে? কারণ 20 - 17, 20 - 17 3, তাহলে এটা ওমেগা 3। তাহলে ওমেগা 3 ফ্যাটি অ্যাসিড কি কি হলো? লিনোলিক হলো, এইটা ওমেগা 3 হলো, আর এটা ওমেগা 3 হলো। কিন্তু অ্যারাকিডোনিক অ্যাসিড যদিও খুব ইম্পর্টেন্ট ফ্যাটি অ্যাসিড, বাট ইট ইজ নট ওমেগা 3. Arachidonic acid is very important fatty acid, precursor of the eicosanoids, but it is not omega 3. It is omega 6. Omega 6 fatty acid is present in source ki? Vegetable oil, soybean oil, sunflower oil, cottonseed oil, linseed oil. All vegetable oils contains predominantly omega 6. কিন্তু omega 3 সামান্য থাকতে পারে। কিন্তু predominantly omega 6 fatty acids are present in vegetable oil, predominantly omega 3 fatty acids are present in fish oil. ইকোসাপেটেড এবার 6টা বলো। 6 এর অ্যাডভার্টাইজমেন্ট দেয়, হটলিক্সের অ্যাডভার্টাইজমেন্ট দেখেছো? দিয়েছে। ফুল ফর্মটা কি? ডোকোসা হেক্সা ইনোইক অ্যাসিড। হ্যাঁ, ডোকোসা কথাটার মানে কি? ডোকোসা ডেকা, সেটা হচ্ছে ডেকা। ডেকা হচ্ছে 10টা। ডোকোসা মানে ইকোসা প্লাস 2 মানে 22। ইকোসা হচ্ছে গিয়ে 20। ডোকোসা মিনস 2 + 20। ডোকোসা মিনস 2 + 20, 22। তাহলে 6 কার্বন যদি 22 হবে, 6 কার্বনের এক্সাম্পল হচ্ছে গিয়ে ডোকোসা হেক্সা ইনোইক অ্যাসিড, ভেয়া। কি হবে? 22। পজিশন অফ দ্য ডবল বন্ড কি হবে? 4 দিয়ে শুরু হবে। 4, 7, 10, 13, 16, 19। তাহলে এটা ওমেগা 3 না ওমেগা 6 হবে? ওমেগা 3 হবে, কারণ 22 - 19 ওমেগা 3। তাহলে কি কি ওমেগা 3 ফ্যাটি অ্যাসিড হলো এই খাদ্যগুলোর মধ্যে? লিনোলিক, ইপিএ আর ডোকোসা হেক্সানোইক অ্যাসিড। তো বলতে হবে একটা কার্বন ডবল বন্ড, দুটো কার্বন, দুটো ডবল বন্ড, 3টে ডবল বন্ড, 4টে ডবল বন্ড, 5টা ডবল বন্ড, 6টা ডবল বন্ড। তার এক্সাম্পলস, তার কার্বন নাম্বারস, তার পজিশন অফ দ্য ডবল বন্ড, and whether it is omega 3 category or omega 6 category. প্রত্যেকটা ওমেগা 3 ক্যাটাগরি কিংবা ওমেগা 6 ক্যাটাগরি হবে। কি করে ওমেগা 3 ক্যাটাগরি হবে আর কি করে ওমেগা 6 ক্যাটাগরি হবে সেটা কিন্তু ক্যালকুলেশন করে বলা যায়। এই 6টা ফ্যাটি অ্যাসিডের এক্সাম্পল একদম পরিষ্কার করে মনে রাখবে। ফলিক অ্যাসিড, লিনোলিক অ্যাসিড, লিনোলিনিক অ্যাসিড, অ্যারাকিডোনিক অ্যাসিড, আইকোসা পেন্টানোইক অ্যাসিড, ডোকোসা হেক্সানোইক অ্যাসিড। এইবারে বলো আর একটা ক্লাসিফিকেশন অফ দ্য ফ্যাটি অ্যাসিড তোমরা বলনি, যেটা আমি বলছি একটা সিস ফ্যাটি অ্যাসিড, আনস্যাচুরেটেড ফ্যাটি অ্যাসিড। cis unsaturated fatty acid or trans unsaturated fatty acid. What is the difference? What is the difference between the cis unsaturated and trans unsaturated? And which are important? which are beneficial and which are harmful. Unsaturated fatty acid is harmful in our body, এই কথাটা বললে কিন্তু এটা ফলস বলা হবে। যদি বলো ট্রান্স আনস্যাচুরেটেড ফ্যাটি অ্যাসিড is harmful our body, it is correct. But all the naturally occurring fatty acids, আমাদের বডিতে যে ফ্যাটি অ্যাসিড থাকে সবটাই কিন্তু সবটাই কিন্তু বেশিরভাগটাই সবটাই সিস ফর্ম অফ দ্য ফ্যাটি অ্যাসিড। সিস ফর্ম অফ দ্য ফ্যাটি অ্যাসিড আর ট্রান্স ফর্ম অফ দ্য ফ্যাটি অ্যাসিডের মধ্যে স্ট্রাকচারের কিরকম তফাৎ হবে? একটা বেন্ট হবে, একটা স্ট্রেট হবে, তাই তো? আমি আগে দেখিয়েছিলাম এখানে সিওইজ আছে, আবার এখানে সিএইচ3 গ্রুপ আছে। এই ধরনের ফ্যাটি অ্যাসিডকে আমরা কি বলবো? সিস। এইটাই হচ্ছে সিস। আর ট্রান্স হবে হাইড্রোজেন অপোজিট সাইডে থাকবে। এইরকম এরকম হবে। তফাৎ কি হবে? এর মধ্যে একটা বেন্ট হবে যেটা যে 120 ডিগ্রি, আর এটা হবে স্ট্রেট। Transforms behaves like saturated fatty acid. Transform is the straight in structure. Cis form is the bent in structure. Cis form is bent in structure, straight in structure. Transform is harmful, cis form is beneficial. সেই জন্য আমাদের বডিতে যে আছে সেটা হচ্ছে সিস ফর্ম। অলিক অ্যাসিড সিস ফর্ম, তার ট্রান্সফর্মটা হচ্ছে এলাইটিক অ্যাসিড। এবং এই যে যে ফ্যাটি অ্যাসিডগুলোর নাম বললাম সবগুলোই কিন্তু সিস ফর্ম, সবগুলোই কিন্তু সিস ফর্ম। এইবার বলো সিস ফর্মটা কেন দরকার, তার ট্রান্সফর্মটা কেন হার্মফুল? আমি তো এক্সাম্পল দিয়ে বলেছিলাম, ধরো এই একটা ঘর, এই ঘরটাকে আমরা একটা দুরকম আয়রন রড দিয়ে আমি ফিল আপ করবো। একটা হচ্ছে স্ট্রেট আয়রন রড, আর একটা হচ্ছে গিয়ে L7 আয়রন রড। আমি যদি স্ট্রেট আয়রন রড দিয়ে যদি ফিল আপ করি তাহলে কিন্তু কম্প্যাক্ট ফিলিং হবে, কম্প্যাক্ট ফিলিং হবে। কিন্তু যদি আমি L7 আয়রন রড দিয়ে যদি ফিল আপ করি এটাকে, তাহলে কম্প্যাক্টনেস হবে না, তাহলে কি হবে? লুজনেস হবে। And that looseness is due to, looseness is the result of, cause of fluidity of the membrane. Looseness is the cause of fluidity of the membrane. Membrane is not rigid in structure. Rigid হলে কিন্তু আমরা বাঁচতাম না। Membrane যদি rigid হতো, life is not possible. Membrane fluid বলেই life is possible. And fluidity of the membrane is essential, and that fluidity is due to cis form of the fatty acid. Cis form of the fatty acid ফসফোলিপিডে থাকে। আমি বলেছি মেমব্রেন লিপিড মানে ফসফোলিপিড। ফসফোলিপিডে দুটো ফ্যাটি অ্যাসিড থাকবে এবং দুটো ফ্যাটি অ্যাসিডের মধ্যে অ্যাটলিস্ট ওয়ান ফ্যাটি অ্যাসিড উইল বি আনস্যাচুরেটেড। দুটো ফ্যাটি অ্যাসিড থাকে ফসফোলিপিডে, তিনটে ফ্যাটি অ্যাসিড থাকে ট্রাইগ্লিসারাইডে। দুটো ফ্যাটি অ্যাসিড থাকে ফসফোলিপিডে, তিনটে থাকে ট্রাইগ্লিসারাইডে। ফসফোলিপিডের দুটোর মধ্যে যে কোনো একটা আনস্যাচুরেটেড থাকবেই। আনস্যাচুরেটেডটাকে আমরা দেখাই কিভাবে দেখাই? এই যদি একটা ফসফোলিপিডের ডায়াগ্রামেটিক স্ট্রাকচার, আনস্যাচুরেটেড ফ্যাটি অ্যাসিডটাকে আমরা দেখাবো। এটা হচ্ছে গিয়ে, একটা হচ্ছে গিয়ে স্ট্রেট হবে, আর একটা হবে একটু বেন্ট হবে, এইরকম হবে। এইটা হচ্ছে গিয়ে এই যে ফ্যাটি অ্যাসিড, এটা হচ্ছে ফ্যাটি অ্যাসিড, এটা হচ্ছে আনস্যাচুরেটেড ফ্যাটি অ্যাসিড, এটা হচ্ছে স্যাচুরেটেড ফ্যাটি অ্যাসিড। দুটো ফ্যাটি অ্যাসিড থাকবে। এটা হচ্ছে হেড অফ দ্য ফসফোলিপিড। হেড কি দিয়ে তৈরি? পোলার হেড ইজ ডিউ টু ফসফরিক অ্যাসিড। ফসফরিক অ্যাসিড হচ্ছে পোলার হেড। আর ফসফরিক অ্যাসিড বাদ দিয়ে গ্লিসারলে আর যে দুটো OH গ্রুপ আছে, কার্বন নাম্বার 1 and কার্বন নাম্বার 2 of the glycerol will contain fatty acid. তার মধ্যে একটা ফ্যাটি অ্যাসিড মাস্ট বি আনস্যাচুরেটেড। এটা অলিক হতে পারে, বেশিরভাগ ক্ষেত্রে এটা অলিক কিংবা লিনোলিক কিংবা অ্যারাকিডোটিক, বেশিরভাগ ক্ষেত্রেই। এবং এদের জন্যই কিন্তু মেমব্রেনটা ফ্লুইড ইন নেচার। এবার আমি এসেছি কোলেস্টেরল সম্পর্কে। কোলেস্টেরলটা রিংটা কিরকম, রিংটার নাম কি, হোয়াট ইজ দ্য নেম অফ দ্য রিং অফ দ্য কোলেস্টেরল? সাইক্লো পেন্টেনো পারহাইড্রো ফিনান্থ্রিন, সংক্ষেপে বলা হয় স্টেরল রিং। সাইক্লো পেন্টেনো পারহাইড্রো ফিনান্থ্রিন রিং, এটা বলতে হবে রিংটার নাম। সাইক্লো পেন্টেনো পারহাইড্রো ফিনান্থ্রিন রিং, এবং এটাকে বলা হয় স্টেরল রিং। কটা রিং থাকে? মনে আছে কিরকম? আমি দেখছি একটু মনে পড়ে কিনা। এটা হচ্ছে বেনজিন, এটা হচ্ছে গিয়ে, এটা হচ্ছে ন্যাপথলিন, এর উপরে একটা থাকবে, এটা হচ্ছে ফিনান্থ্রিন, এরপরে হচ্ছে সাইক্লোপেন্টানো ফিনান্থ্রিন রিং। এই চারটে মিলে ABCD, ABCD, A প্লাস B প্লাস C প্লাস D হচ্ছে সাইক্লোপেন্টানো পারহাইড্রো ফিনান্থ্রিন রিং। দিস ইজ প্রেজেন্ট ইন কোলেস্টেরল। এটা কোলেস্টেরল থাকবে, এছাড়াও সাইড থাকবে, এখানে থাকবে, এখানে থাকবে। তাই তো? এটা হচ্ছে 26 কার্বন, এটা হচ্ছে 27 কার্বন। ঠিক আছে, 27টা কার্বন কোলেস্টেরলে। কটা হাইড্রোক্সিল গ্রুপ থাকবে? কোথায়? এটা হচ্ছে 1 নম্বর, এটা হচ্ছে 2 নম্বর, এটা হচ্ছে 3 নম্বর, এখানে থাকবে। দিস ইজ কোলেস্টেরল। আমাদের বডিতে কোলেস্টেরল কি হিসাবে থাকে? মেনলি কোলেস্টেরল এস্টার ফর্মে থাকে। টু থার্ড অফ দ্য কোলেস্টেরল ইজ প্রেজেন্ট, স্যাটিসফাইড হবে। এটা হচ্ছে ফ্রি কোলেস্টেরল, আমি যেটা আঁকলাম। আর এটা হচ্ছে গিয়ে কোলেস্টেরল এস্টার, that is RCOH, fatty acid. Fatty acid is esterified with OH group of the cholesterol, single OH group at three position. That is called cholesterol ester. Now, cholesterol is a derived lipid. Remember, cholesterol is the derived lipid, but cholesterol ester is a simple lipid. By definition of the simple lipid, cholesterol is the simple lipid because it is the ester of fatty acid and alcohol. এটা ester of fatty acid and alcohol. তাহলে fatty acid এবং alcohol এর ester মানে simple lipid. তাহলে simple lipid ট্রাইগ্লিসাইড ছাড়াও যদি simple lipid বডিতে থাকে, that is cholesterol ester. Simple lipid ট্রাইগ্লিসাইড ছাড়াও যেটা থাকে আমাদের বডিতে, that is cholesterol ester. But cholesterol is derived lipid. কারণ কোলেস্টেরল কিন্তু সিম্পল লিপিডের মধ্যে পড়ে না, এখানে কোনো ইয়ে নেই, ফ্যাটি অ্যাসিড নেই, কমপ্লেক্স লিপিডের মধ্যে পড়ে না, এটা পড়ছে ইম্পর্ট্যান্ট ডিরাইভড লিপিড দ্যাট ইজ প্রেজেন্ট ইন আওয়ার বডি ইজ দ্য কোলেস্টেরল। কোলেস্টেরলের দুটো এফেক্ট আছে, একটা হচ্ছে হার্মফুল এফেক্ট, একটা হচ্ছে বেনিফিশিয়াল এফেক্ট। তো ভালো দিকটা কি কোলেস্টেরলের? ব্রাইট সাইডটা আগে বলি, তারপরে ডার্ক সাইডটা পরে বলবো। ব্রাইট সাইড হচ্ছে গিয়ে কোলেস্টেরল is converted to normally in metabolism. Cholesterol metabolism যদি আমি বলি, normal fate of the cholesterol in the liver is the formation of the bile acid. Bile acid দরকার তো, এবং that bile acid is coming from cholesterol. এবার বলো কোন ভিটামিন কোলেস্টেরল থেকে তৈরি হয় আর কোন হরমোন কোলেস্টেরল থেকে তৈরি হয়? ভিটামিন ডি ইজ কামিং ফ্রম কোলেস্টেরল আর স্টেরয়েড হরমোনস আর কামিং ফ্রম কোলেস্টেরল। তাহলে কোলেস্টেরলের বেনিফিশিয়াল ইফেক্ট হচ্ছে গিয়ে ফর্মেশন অফ দ্য বাইল অ্যাসিড, সিনথেসিস অফ দ্য ভিটামিন ডি, সিনথেসিস অফ দ্য স্টেরয়েড হরমোনস। এছাড়াও আরও একটা ফাংশন কোলেস্টেরল আছে, that is cholesterol is present in the cell membrane. Cholesterol is the present in the cell membrane, important component of the cell membrane, because it modulates fluidity of the membrane. It prevents over rigidity as well as it prevents over fluidity. মেমব্রেন যখন রিজিড হতে যাচ্ছে, খুব শক্ত হতে যাচ্ছে, তখন সেই ওভার রিজিডিটিটাকে প্রিভেন্ট করছে। আর মেমব্রেন যদি ওভার ফ্লুইড হতে যায়, খুব বেশি ফ্লুইড হতে যায়, তাহলে সেই ওভার ফ্লুইডিটিটাকেও চেক করছে। সেই জন্য কোলেস্টেরলকে বলা হয় মডিউলেটর অফ দ্য মেমব্রেন ফ্লুইডিটি। ভেরি ইম্পর্টেন্ট ফাংশন অফ দ্য কোলেস্টেরল। দিজ আর দ্য অল ব্রাইট সাইড অফ দ্য কোলেস্টেরল or beneficial role of the cholesterol. হ্যাঁ, কোলেস্টেরলের যদি পরিচয় হয়, কোলেস্টেরল এইভাবেই পরিচিত হওয়া উচিত। কিন্তু যেভাবে কোলেস্টেরলের পরিচয় আমরা করি, সেটা কিন্তু ডার্ক সাইড অফ দ্য কোলেস্টেরল, বিকজ কোলেস্টেরল লিডস টু হাইপারকোলেস্টেরলেমিয়া and hypercholesteremia leads to coronary artery disease. This is not the usual role of the cholesterol. This is the unusual role of the cholesterol and dark side of the cholesterol. ফসফোলিপিড বলো ভাই, ফসফোলিপিডটা একটু বলে দিচ্ছি, তাহলে মেমব্রেন লিপিডটা শেষ হয়ে যাবে। Phospholipid is the one of the important complex lipid. One of the important complex lipid. The সবচেয়ে important complex lipid, that is called phospholipid. সবচেয়ে important simple lipid, that is triglyceride. সবচেয়ে important derived lipid, that is cholesterol. Phospholipid মানে দু রকম। একটা হচ্ছে কি, যদি গ্লিসারল ব্যাকবোন থাকে তাহলে তাকে গ্লিসারোফসফোলিপিড, যদি স্ফিঙ্গোসিন ব্যাকবোন থাকে তাকে বলবো স্ফিঙ্গোফসফোলিপিড। তাহলে ফসফোলিপিড মানে দু রকম, গ্লিসারোফসফোলিপিড, স্ফিঙ্গোফসফোলিপিড। স্ফিঙ্গোফসফোলিপিডের বেস্ট এক্সাম্পল হচ্ছে গিয়ে স্ফিঙ্গোমাইলিন। হোয়াট ইজ দ্য কম্পোনেন্ট অফ দ্য স্ফিঙ্গোমাইলিন? স্ফিঙ্গোমাইলিনে কি কি থাকবে? স্ফিঙ্গোসিন থাকবে, ফ্যাটি অ্যাসিড থাকবে। স্ফিঙ্গোসিন আর ফ্যাটি অ্যাসিড মিলে যে কম্পাউন্ড, তার নাম হচ্ছে কি সিরামাইড। স্ফিঙ্গোসিন আর ফ্যাটি অ্যাসিড মিলে যে কম্পাউন্ড, তার নাম হচ্ছে সিরামাইড। সিরামাইডের সঙ্গে যদি ফসফরিক অ্যাসিড এবং কোলিন, তার মানে কি, তার কি কি হলো? স্ফিঙ্গোসিন, ফ্যাটি অ্যাসিড, ফসফরিক অ্যাসিড, কোলিন। এই চারটে কম্পোনেন্ট থাকবে স্ফিঙ্গোমাইলিনে। আর গ্লিসারোফসফোলিপিডের এক্সাম্পল কি? হোয়াট আর দ্য এক্সাম্পলস অফ দ্য গ্লিসারোফসফোলিপিডস? লেসিথিন। লেসিথিন হচ্ছে কি জিনিস? আগে স্ট্রাকচারটা বলো লেসিথিনের। কি থাকে? ফসফ্যাটিডিল কোলিন। ফসফ্যাটিডিল কোলিন মানে ফসফ্যাটিডিক অ্যাসিড। ফসফ্যাটিডিক অ্যাসিডের ফসফরিক অ্যাসিড is attached to choline. What is phosphatidic acid? Phosphatidic is the simplest phospholipid. Simplest phospholipid হচ্ছে গিয়ে phosphatidic acid. কি it is coming from glycerol. এখানে একটা ফ্যাটি অ্যাসিড দিয়ে স্ট্রাটিফাইড হলো, এটা একটা ফ্যাটি অ্যাসিড দিয়ে স্ট্রাটিফাইড হলো, এটা কিন্তু ফ্যাটি অ্যাসিড দিয়ে স্ট্রাটিফাইড হবে না। তার বদলে কোন অ্যাসিড দিয়ে স্ট্রাটিফাইড হবে? এই দুটো কিন্তু ফ্যাটি অ্যাসিড দিয়ে স্ট্রাটিফিকেশন হলো, দুটো অ্যালকোহল। এই অ্যালকোহলটাও ফ্যাটি অ্যাসিড দিয়ে হলো, এই অ্যালকোহলটা কিন্তু ফ্যাটি অ্যাসিড দিয়ে স্ট্রাটিফিকেশন হবে না। কি অ্যাসিড দিয়ে স্ট্রাটিফিকেশন হবে? ফসফরিক অ্যাসিড। এই কম্পাউন্ডটার নাম হচ্ছে গিয়ে সিম্পলেস্ট ফসফোলিপিড, যার নাম হচ্ছে ফসফ্যাটিডিক অ্যাসিড বা ফসফ্যাটিডেট। ফসফ্যাটিডিক অ্যাসিড, এই ফসফ্যাটিডিক অ্যাসিড হচ্ছে গিয়ে সিম্পলেস্ট ফসফোলিপিড। এবার এখানে দিস ইট ইজ রিপ্লেসড বাই সামথিং আননোন। When X is serine, it is called phosphatidyl serine. When X is choline, it is called phosphatidyl choline. When X is ethanolamine, it is phosphatidyl ethanolamine. When X is inositol, it is phosphatidyl inositol. These are all glycerophospholipids. These are all glycerophospholipids which are present in the cell membrane. তাহলে এক্স এর উপর ডিপেন্ড করছে নেচার অফ দ্য ফসফোলিপিড। কোলিন হলে যেমন লেসিথিন, লেসিথিন কি? ফসফ্যাটিডিল কোলিন। লেসিথিন যখন সারফ্যাক্ট্যান্ট তখন তার কি নাম? when lecithin acts as a surfactant, it is called di-palmitoyl lecithin. তার মানে এখানে যে দুটো ফ্যাটি অ্যাসিড আছে না, দুটি হচ্ছে পামিটিক অ্যাসিড। এটা দুটি পামিটিক অ্যাসিড আর এটা হচ্ছে কোলিন। তাহলে এই রকম স্ট্রাকচারের যদি হয় সেটাকে বলছি লেসিথিন, যেটা সারফ্যাক্ট্যান্ট হিসেবে ব্যবহার হয়। সারফ্যাক্ট্যান্ট মানে ইট রিডিউসেস দ্য সারফেস টেনশন। এবং এটা কি কাজ, কি লাংসে কি করে? হোয়াট ইজ দ্য বেনিফিশিয়াল ইফেক্ট? ইট প্রিভেন্টস, ইট কোলাপস করতে সাহায্য করে না প্রিভেন্ট করে? ইট প্রিভেন্টস কোলাপস অফ দ্য লাং। ইট প্রিভেন্টস কোলাপস অফ দ্য লাং অর অ্যাটলেক্টোসিস। যদি না থাকে তাহলে কি হবে? লেসিথিন যদি অ্যাবসেন্ট থাকে কোলাপস হবে, তখন রেসপিরেটরি প্রবলেম হবে এবং সেটাকে আমরা বলি রেসপিরেটরি ডিস্ট্রেস সিনড্রোম, আরডিএস। আরডিএস এটা যখন অ্যাডাল্টের হয় তখন আমরা বলি অ্যাডাল্ট রেসপিরেটরি ডিস্ট্রেস সিনড্রোম। অ্যাডাল্ট রেসপিরেটরি ডিস্ট্রেস মানে এআরডিএস। ইউজুয়ালি এটাকে আরডিএস বলা হয়। আরডিএস মানে রেসপিরেটরি ডিস্ট্রেস সিনড্রোম। ইট ইজ ডিউ টু absence or deficient synthesis of the lecithin, thereby promoting collapse of the lung. লেসিথিনের ইম্পর্টেন্স আছে। তাহলে সেফালিন আছে। সেফালিন কাকে বলে? হোয়াট ইজ সেফালিন? ফসফ্যাটিডিল ইথানোলামিন। লেসিথিন হচ্ছে ফসফ্যাটিডিল কোলিন। কোলিন হচ্ছে নাইট্রোজেনাস বেস, নাইট্রোজেনাস কম্পাউন্ড। ইথানোলামিন হচ্ছে নাইট্রোজেনাস কম্পাউন্ড। These are all phospholipids and important phospholipids present in the mitochondria of the heart. Important phospholipids that is present in the mitochondria of the heart. তাকে কি বলে? হার্টের কার্ডিওলিপিন। Cardiolipin is a diphosphatidylglycerol glycerol. Chemically, cardiolipin is a diphosphatidylglycerol. এই দুটো ফসফ্যাটিডিক অ্যাসিড থাকবে, মাঝখানে একটা গ্লিসারল থাকবে। ডাইফসফ্যাটিডিলগ্লিসারল হচ্ছে গিয়ে কার্ডিওলিপিন। ইম্পর্টেন্ট ফসফোলিপিড প্রেজেন্ট ইন দ্য মেমব্রেন অফ দ্য মাইটোকন্ড্রিয়া। হুইচ মাইটোকন্ড্রিয়া? কার্ডিয়াক মাইটোকন্ড্রিয়া। হার্টের যে মাইটোকন্ড্রিয়া তার যে মেমব্রেন আছে সেই মেমব্রেনে থাকবে লিপিড, তার নাম হচ্ছে গিয়ে কার্ডিওলিপিন, ইম্পর্ট্যান্ট লিপিড প্রেজেন্ট ইন দ্য হার্ট, ফসফোলিপিড। তাহলে ফসফোলিপিড সম্পর্কে অনেক সময় থাকে, ফসফোলিপিড শর্ট নোট থাকবে, ফসফোলিপিড কোথায় থাকে বলতে হবে, ফসফোলিপিড ক্লাসিফিকেশন বলতে হবে, ফসফোলিপিড এক্সাম্পল দিতে হবে। তাহলে আমরা ট্রাইগ্লিসারাইড সম্পর্কে বলেছি, ফসফোলিপিড সম্পর্কে বলেছি, কোলেস্টেরল সম্পর্কে বললাম, ফ্যাটি অ্যাসিড সম্পর্কে বললাম। এই প্রশ্নগুলো কিন্তু থাকবে সমস্ত এক্সামিনেশনে।
Anyway, good morning. Your results are out? Okay. So, too early to... Whenever you study any topic, or whenever you write any answer to impress the examiner, you must follow certain footsteps. Okay. So, you have to impress the examiner, right? So, you have to follow certain footsteps because examiner will not have time to go through every details that you have written. So, how to impress an examiner? So, you have to write a content. Content means under which you're going to write the answer, or under the headings based on which you're going to teach a topic. So, our topic for today is cell injury. So, these are the contents. There will be an introduction part. There will be the causes of cell injury. What are the various morphological alterations that takes place? The mechanisms of cell injury. And finally, we were going to end with a few examples. Okay, so that's how we are going to deal with cell injury. Settle down, settle down. So when we talk about cell injury, the introduction is basically a little on pathology. Put your leg down. The introduction will be a little on pathology. So if I ask you, if I show you these two pictures, one lady on the left hand side and one lady on the right hand side. So based on this picture, you tell me which lady are you going to study today? Out of these two ladies, which one are you going to study today? On the right hand side. Why? Can you differentiate between these two ladies? So left hand side, which subject she belongs to? If she belongs to the right hand side lady belongs to our topic. I mean, not our topic, our subject, the subject that we are studying today, which is pathology. The lady to the left hand side, where does she belong to? Why do you think this lady, we are going to study about this lady today? What makes you think that we're going, I'm asking you one question. You said we are going to study about the lady on the right hand side. Why? What makes you think so? Pathology is the study of suffering. Very good. So she is suffering, right? Clinically, you can make out she is in pain. Whereas on the other hand, the lady on the left hand side, she looks absolutely fine. She looks jovial. She's smiling. So which subject she belongs to? Physiology. Because you have studied physiology, if you do not study physiology, you will never, and if you do not study anatomy, especially, you will not be able to study pathology. If you do not know what physiology is, if you do not know what normal is, the mechanism, the physiology, which will help you to study the etiopathogenesis, and if you do not know histology, especially in anatomy, which part of anatomy? I'm not talking about embryology or osteology, but histology. So if you do not know histology, if you do not know how hepatocytes look like, or if you do not know the normal histology of liver, you will never be able to appreciate what happens in a fatty liver, what happens in case of a cirrhosis of liver, what morphological alterations take place. That is the importance of studying. That is the importance of knowing first year subjects, especially anatomy and physiology. Okay. Pathology is basically the backbone of medicine. I do not say this. William Osler had said this. I don't say this. William Osler said this. As is your pathology, so is your practice. Because if you do not know the etiopathogenesis of a disease, you will never be able to diagnose any disease. Am I audible? You will never be able to diagnose a disease. In that case, as a physician, you will be a massacre, you will be a failure. So as is your pathology, so is your practice. If you want a good practice, you should have a sound knowledge on your subject, and this sound knowledge is going to come, it depends on how strong your pathology is. So as is your pathology, so is your practice. William Osler had said this. So having given you a brief introduction on pathology, now coming to the main part. So what is pathology? Pathology is basically the study of diseases. Patho means diseases, logos means study. So pathology is basically the study of diseases. So what we do here? Pathology is basically what? Study of diseases. So what changes takes place in pathology? It's basically the changes in cells and tissues that happens during a diseases. The morphological, the biochemical, the structural changes that takes place in cells and tissues during a disease. For example, you know a normal liver, the histology of a liver. Consider a histology of liver. You know how the hepatocytes look like. Then you know the central veins, the hepatic artery, the portal triad. You know the size of a liver. You have better knowledge than me because you're fresh from anatomy. And you know the weight of a liver. That is a normal liver, which you have studied in anatomy. Now let's consider a fatty liver. What happens in a fatty liver? What morphological changes takes place in a fatty liver? Fat accumulation, a person drinking too much can acquire a fatty liver. So there will be accumulation of fat, which will cause increase in the size of the organ. Hepatomegaly, very good. So that is the morphological alteration that takes place, or the structural alterations that take place. And if the person keeps on, do not stop drinking, if he doesn't cut down on his alcohol consumption, this fatty liver can progress to what? Cirrhosis. So initially, the liver will be big. Ultimately, what will happen in case of a cirrhosis? The liver will shrink. It will become smaller. So that is the morphological alteration. So biochemical, structural and morphological alterations that takes place in an organ during a disease. So pathology basically explains the whys and whereofs of the clinical signs and symptoms manifested by the patient. See, pathology is in second year. When you go in practice, the patient will never come and tell you that I have this particular disease. I have this particular disease. For example, a patient presents with So a patient presents with cough, fever, weight loss, right? These are the clinical manifestation. You can see it, right? These are the clinical manifestations. You do a physical examination and there is a sputum, cough with sputum. You do a physical examination of the patient and you see one enlarged cervical lymph node. You see a patient presents to you with cough, sputum production, fever, weight loss, evening rise of temperature. Okay, you guessed what it is. Tuberculosis, you have guessed it. But you need to, theoretically you are correct, but you need ancillary tests to confirm your diagnosis. You do a physical examination and you see an enlarged cervical lymph node. So, what do you order? In this case, what do you order? In this case, what do you order? Say you order an investigation, you write complete blood count. You do a CBC, a complete blood count, which will include a ESR. ESR will be raised in tuberculosis. I hope that the ESR will be raised in tuberculosis. Then you give a sputum for AFB. What is AFB? Acid fast bacilli. Acid fast bacilli. So they will do a, have you heard of it? They will do a ZN stain, a Ziehl-Neelsen stain. Then for this enlarged lymph node, you order a FNAC of cervical lymph node. Now fever can be due to many causes. Fever can be due to many causes. Weight loss can be due to many causes. A cough can be due to many causes. But slowly but steadily, you're moving towards a diagnosis of tuberculosis. So remember, a patient will never come and ask you, say, I have tuberculosis. Or give me this test. Give me a CBC, give me a ESR, give me a sputum examination, order a sputum examination for me, do a cervical lymph node FNAC. No, patient will never do that. The patient will come and present you with clinical manifestations. I have cough, fever, I have this, that. You as a physician, with tons of knowledge into your account, you have to come to a diagnosis. So theoretically, you have come to a diagnosis of tuberculosis. Now your theory must be backed up by your practical knowledge. So you order a few ancillary tests. You order a few ancillary tests. So what are these ancillary tests? The CBC, ESR, these are all the laboratory tests that you have ordered. This is exactly what is meant by this particular sentence. It explains the reason behind the signs and symptoms manifested by the patients using various techniques. Various immunological techniques, microbiologic techniques, biochemical techniques, pathologic techniques, hematological techniques, whatever the techniques are. These techniques helps you to finally explain the reason behind the signs and symptoms manifested by the patient. You got this sentence? Patient will present with clinical manifestations. With the clinical manifestations, as a physician, you will come to a diagnosis, you'll have a provisional diagnosis. Now to make your diagnosis correct, or in order to confirm your diagnosis, you order many ancillary tests. A few, not many, a few ancillary tests. And these are the tests you order. So basically, this is a final year subject. Entire thing is a, for example, this thing belongs to final year, right? You'll see in clinics. These are in clinics. And these are all the investigations that you get in, say, second year. This belongs to what? Lab medicine. So this is clinical medicine on one hand, and lab medicine is on the other hand. So basically, not only pathology, but pathology, biochemistry, and microbiology, they come under one umbrella. That is called lab medicine. Right? You got this? Is it clear? Is it clear? You'll be studying more in clinics about all these things. So basically, not only pathology, but also all this microbiology and biochemistry, all the subjects that comes under the rubric of lab medicine, they form a, what do they form? What is this? What is this? They form a bridge between the second year and final year subjects. Between the, I shouldn't use the word second year or final year, between the signs and symptoms manifested by the patient and the lab investigations. So this is the importance of lab medicine. So they form a bridge. Is this line clear? Is this concept clear? Now tell me yes or no. Otherwise, I'm going to explain again if it's not clear. Pathology, or the second, or the lab medicine, basically acts as a bridge between the final year, the clinical manifestations, and the signs and symptoms manifested by the patient. Clear? Should I explain again, or you need another explanation? Let me know. Okay, to the next slide without knowing. So pathology can be divided now into generalized pathology and general pathology, not generalized, that is general pathology and systemic pathology. You will come to know this is so basically what we are studying now is general pathology. Okay. So now coming to the core of pathology. Core of pathology, I like to explain things based on diagrams rather than on theory. So if you're if you're interested in my classes, or if you follow my classes keenly, you'll see I'll be explaining more on diagrams rather than like putting too much of theory. Okay, so what you have to do is, what I teach now, you have to go back and start reading it. Otherwise, you'll not get a concept, because I'll be teaching more, I'll be writing something, but I'll be explaining more on based on diagrams. So core of pathology, pathology is formed of 4 things. You must remember. One is etiology. Etiology, the causes of a disease. The causes of a disease. What can cause a disease? That is one thing. Number 2, what can this be? This is the pathogenesis. This is the pathogenesis. Number 3, what are this? Morphologic changes that takes place in the cells and tissues. Morphologic changes that takes place in cells and tissues, reversible and irreversible. I'll come to that later. And final one is the outcome. The outcome. How the patient manifests. There has been you have been infected with, somebody has been, not you, somebody has been infected with a coronavirus. Okay. So that is the etiologic agent. Right, that is the etiologic agent. Number 2 will be how the coronavirus replicates inside the body. That will be the pathogenesis. Number 3 will be morphologic changes. What happens in how the patients manifested during corona. Most of the corona patients, what killed the patients? Respiratory problems. So basically lungs were affected. What morphological changes took place in the lung of that patient? And finally, the manifestations. Breathing problems. Right? So patient will come to you in a reverse manner. The sequence will be reversed when you see a patient. Here I have explained you, okay, coronavirus has entered, it has replicated inside the body, certain morphological changes have taken place in the lung, and that's why the patient presented with respiratory problems, breathlessness. But patient here will present to you, just like I have explained in the previous paragraph, previous slide, patient will never present you, come and say that I have coronavirus, though patient may know. Okay, this is an example. So patient will come to you with breathing problems. Patient will come to you with what? Breathing problems. And you have to, based on the theory knowledge that you have to realize, or you have to come to a diagnosis that this patient is suffering from some respiratory problem. It can be a SARI, okay, severe acute respiratory illness, or it's a corona, whatever it may be. Then you have to think in terms of the etiology, pathogenesis, and morphologic changes. And to come to that, you have to order certain tests. This is the role of lab medicine. This is where lab medicine comes into play. How many of you, actually you guys have not seen corona because we were there. No patients were allowed in a corona ward without a proper positive corona result, corona report. Now who will do that? Department of Microbiology. That is also lab medicine. Right? No patients were allowed in a corona ward without a proper valid positive corona result. Who did that? Microbiology. Here, even though I'm teaching pathology, but microbiology is also a part of lab medicine. So I'm explaining a little on microbiology also. Who did that? Microbiology. Means lab medicine. Clinical manifestation versus lab medicine. So this is the bridge basically. This is the importance of doing a lab medicine. your theory knowledge must be backed up by your practical tests. Clear? That is the importance of studying lab medicine. So core of pathology is formed of 4 things. Etiology, what is the cause? So what can be the cause? If you look back into history, when people did not know about the causes of the diseases, people used to say it is because the deceased person has done some kind of a sin or has done some kind of a crime. That's why God has convicted him with all these problems. But no, that is not the reason. Now we know there are 2 causes. Basic 2 causes. One is genetic cause and the other one is acquired. So what can be the acquired cause? Any kind of infection, whatever the causes may be. So I'm not getting into the details of that. Genetic causes, this you must be knowing, at least in physiology and all you have studied. Genetic causes and acquired causes. Genetic is inborn, acquired is not inborn. That's why it's called acquired cause. Okay, first one is that, causes, etiology. Next one is mechanism of development, pathogenesis. And to know pathogenesis, you must, right now, the human genome has been mapped. We know many genes which are responsible for various diseases. For example, I took the example for, say, cystic fibrosis. In cystic fibrosis, we know the mutant gene which causes cystic fibrosis, but that is not enough. You must also know the biochemical and the morphological alterations that takes place. What causes the cysts in the lungs and pancreas and various other organs? So knowing just one cause is not enough. You must also know, one thing is not enough. You must also know the other things. For example, even if you know the mutant gene, that is not enough. You must also know the various morphological alterations, the biochemical changes that takes place in the lungs or in the pancreas or various other organs which are affected by cystic fibrosis, which results in the formation of cysts. That is one example. Just like that, just like tuberculosis, knowing Mycobacterium tuberculosis is not enough. Knowing HIV is not enough. But you have to know what exactly happens, how the HIV virus replicates, that basically takes your immunity down. How does a Mycobacterium tuberculosis, M. tuberculosis react in your body, which finally paves the path for the various clinical manifestations? How Gons complex happens, how Gons focus happens, how there is a cervical lymphadenopathy, how spines can be affected, which we call a spot spine. So that is basically the pathogenesis. Number 3 are the morphological changes. Biochemical and structural alterations in the cells induced by the disease. Biochemical and morphological alteration in the cells induced by the disease. That is called mechanism of development. That is called the morphologic changes. Just as I have explained you, cirrhosis of liver. What happens in cirrhosis? Any idea what happens in cirrhosis? What is the basic thing? Applied anatomy. Tissue damage? I know tissue damage. That's why you're studying pathology. So what happens? Fibrosis, bridging fibrosis, formation of nodules. Why those things take place? That is the morphologic changes. Why a liver shrinks? In fatty liver, why a liver increases in size? Why? It's because of deposition of what? Fat. Then it progresses to a stage of cirrhosis. If the person do not cut down on his alcohol consumption, it will go into a stage of cirrhosis. What happens in cirrhosis? Why the liver shrinks in size? Yes, but what happens there? For example, there will be some hepatocytes which die and some hepatocytes which will survive. So there's basically a tug of war between the hepatocytes which survive and the hepatocytes which are dying, ultimately resulting in formation of nodules, then bridging fibrosis. All this you'll study. I'm not getting into the details of that, but all these things you're going to study when you study about cirrhosis. And finally, the functional consequences of these changes. Functional consequences, find out the functional consequences of these changes, which is the clinical manifestation. hepatic failure, portal hypertension, in case of say, cirrhosis of the liver, ascites, edema, right? Physiology. Is this point clear? Is this slide clear? Then only I'll proceed to the next slide. Clear? Sure. So core of pathology is formed of four things. That is the etiology, that is the cause of the disease. Number two, excuse me, pathogenesis, that is the mechanism of development. Number three, morphological changes, which means biochemical and structural alteration in cells and tissues. And finally, the clinical manifestation, functional consequences of these changes, ultimately how the patient presents clinically. So in practice, you won't get this sequence, but everything will be in a reverse sequence, right? এখানে যদি 1 2 3 4 করি cause number 1, number 2 mechanism of development, number 3 biochemical and morphological changes, number 3 clinical manifestations, in practice ground reality তে কি পাবে? উল্টোটা পাবে. Patient will present with the clinical manifestations, right? এই জিনিসটা মাথায় রাখতে হবে. So this is something that you have to keep in mind. Okay, clear? Okay, so I'm going to the next slide. How does a cell respond to stress? How does a cell respond to stress? I won't keep this class too long. Again, tomorrow morning I'll be taking a class. How does the cell respond to stress? Suppose consider a person. Consider a person going to the gym for the first time. Consider a person going to the gym for the first time. And say he wants to do an exercise of, which muscle is this? Tell me. Traps, trapezius. So what he has to do? This is shoulder. So what he has to do? Shrugs, right? So he takes weight for the first time, and the instructor tells him, because you're doing it for the first time, take it with a 5-kilo dumbbell. Take 2 dumbbells and do a shrug. Say after 2 days of doing it, what changes can happen? Your muscles, they are of a particular size. So when you start working on it, or you say working on your biceps, or you start working on your back, say latissimus dorsi, and you start doing all the pulls and all, what changes can happen? There will be increase in the size of the muscle fibers. And because of that, you'll get a little bit of pain, right? So basically, this person has been subjected to a condition of stress. You are leading a normal life, then you start going to the gym, or forget gym, after many days, who plays cricket, you start bowling. Do this full hand bowling. See the pain that happens in the pectoralis region. Why? Same thing, because you have been exposed to a situation of stress. You were stressed out. Basically, that takes you, but you have not injured yourself. You are perfectly healthy. You have not gone to the hospital, right? So what is that condition called? Adaptation. When you are exposed to stress, you adapt yourself to that kind of condition. Clear? When you are exposed to stress, you adapt yourself to that kind of condition. You have come from home, you're not in a mood to study, but you have an exam coming up. You have to adapt yourself to that kind of situation. You used to study, say, 6 hours a day. Before exam, you're studying for 12 hours a day. So that extra 6 hours is because you were in a state of stress. And if you cope up with that, you have adapted yourself. Right. Now, take the same example of this guy going to the gym. Instead of the person picking up a 5-kilo dumbbell, picks up a 25-kilo, try to pick up a 25-kilo dumbbell, what can happen then? No, what can happen then? What can happen then? Why people in gyms, why the trainers in gyms say don't pick up too much of weights? The most dangerous is the back, I'm telling you, because I do gym, I'm telling you the most dangerous is the back. If you do a deadlift, have you heard of a deadlift, a condition of deadlift? You try to do a deadlift, have never done it, and you pick up a 25, 30 kilo, try to do it for the first time, the most important thing that can happen is injure your lower back. And if that happens, you may be crippled. If your luck is bad, you can be crippled for the rest of your life. It's dead. It can kill you, literally. Deadlift is so dangerous. If that happens, why that has happened to you? Say you've picked up a 25 for your shrugs and you totally rupture some of the muscle fibers. Here you are not exposed to stress, but you are exposed to literally an injurious stimuli. You're literally exposed to an injurious stimuli. So that is called a cell injury. That is called a cell injury. And sometimes stress can be so severe that it can also cause cell injury. So normal cell, it's in a stage of homeostasis. You put it in a state of stress. You put it in a state of stress where the body is able to adapt. So that is called adaptation. If this stress continues and your body fails to adapt, it can injure your cells. That is cell injury. And also, instead of stress, the body is exposed to an injurious stimuli. There can be many injurious stimuli, which I'm going to talk about tomorrow, or if there is time, I'll talk today, that can injure your cell. So either you adapt to the situation, or there is a cell injury. Now, if the cell injury is mild or transient, just remember it. Cell injury is mild or transient. These are just crude examples I'm taking. If the injury is mild or transient, that is called reversible cell injury. Means the injury reverts back to normal. The injury reverts back to normal. You see, not India, I won't take example of India, but if you see YouTube videos and say, for example, United States, Russia, say United States, their law and order is actually very good. And say 11, 12 years old guy, because they're allowed to have guns with them, sometimes they shoot. Or sometimes they cause petty crimes for which they're not sent to the jail, but they're sent to a juvenile court. So that is basically some kind of a reverse that can be equated to a reversible injury. Okay, the guy is young. The law and order, the law says that a person below this particular age will not be sent to the prison, but should be sent to a center where he or she can adapt and change himself, get back to normal life. That is equal to a reversible cell injury. If the injurious stimuli is removed, the cell reverts back to normal. So either the cell adapts or the cell goes into a state of injury. If the stress is not too much, the cells will adapt and finally get back to normal homeostasis, to its normal position. Clear? But if the injurious stimuli is severe and progressive, it keeps on persisting, severe and progressive cell injury will take you to a state of irreversible injury. Irreversible injury, like, for example, say heart attack, myocardial infarction. Myocardial infarction doesn't happen all of a sudden. You know the various arteries which supply the heart, and then even if they are blocked, the person do not manifest because there will be formation of what? Collaterals. Only when the collaterals are damaged or the collaterals are also blocked, that's when absolute cessation of blood flow to the myocardium causes a myocardial infarction. That is irreversible injury. So if the injury is persistent, if the injury is severe and it keeps on progressing, the cell goes into a state of irreversible injury. The cell goes into a stage of irreversible injury. Irreversible injury is manifested, means basically irreversible injury is equivalent to what? Cell death. Irreversible injury is equivalent to what? Cell death. Means irreversible injury means the cell is dead. End of the story. Cell has been killed. That is manifested by two ways. One is necrosis. You know what is necrosis? Poche jawa basically. Khati banglaয় poche jawa, necrosis. And the other one is apoptosis. Have you heard of these two terms? Necrosis and apoptosis. What is apoptosis then? Huh? Programmed cell death or suicidal cell death. The cells destined to die, they know that they are dying, so they activate their own enzymatic machineries which degrades them basically. Okay, so this is a cellular response to stress. You should know, because what, you know why I'm stressing so much on this? Because if you have a concept, Philadelphia chromosome CML পাবে তুমি T922. Okay, ঠিক আছে. So has that anything to do with this one? Okay, so is this slide clear? There's a normal cell, or you think of yourself, you are exposed to a kind of stress, you either adapt or you go into some kind of, say, a condition where you are not being able to adapt. Say you fall ill, a person falls ill. Okay, if that injurious stimuli is not progressive, it is not severe, it's mitigated, the person gets back to health. The cell gets back to health. But if the injury is severe and progressive, the cell goes into a stage of irreversible injury, a point of no return. And that point of no return is basically what? Death of the cell. That is cell dead. The cell has died. So that is manifested, the cell death is manifested by two forms. There are two ways a dead cell can manifest. One is the two types of death basically. One is necrosis, the other one is apoptosis. That's how it is. So now, are these slides clear? So before ending, I'll be talking a little on the causes of cell injury. But tell me, have you understood these slides? Sure. Thank you. So what are the causes now? Look into the pictures and tell me what can be the first cause. Hypoxia. Very good. Oxygen deprivation. How do you know that is oxygen deprivation? Huh? So what happens in a tree? Photosynthesis, right? Okay, very good. So what can be the causes of hypoxia? Yes, that is the first one is hypoxia. So what can be the cause of hypoxia? What is the difference between hypoxia and anoxia? What is the difference? Yes, what is hypoxia? Anyone? What is lack of oxygen? You must be very clear what is hypoxia and what is anoxia. Anoxia means total absence of oxygen. Hypoxia means deficiency of oxygen. Hypoxia means deficiency of oxygen. There's a difference. But hypoxia can, and forget anoxia. Actually, I've studied in some biology books that no living beings can survive in a stage of anoxia. But yeah, in hypoxia, you can survive for a while, then it goes into a stage of irreversibility, a point of no return, the cells. Okay, so hypoxia. So what can be the cause of hypoxia? Like in decreased oxygenation of blood, decreased oxygen carrying capacity of blood. What are the causes of decreased oxygen carrying capacity of blood? Anemia. Then decreased oxygenation of blood, decreased oxygen carrying capacity of blood, say blood loss, etc., etc. So these are the various causes of hypoxia. Simple causes. You know what they can be. What is the next one? So person is face is covered in bandage. Yeah. Physical. Yeah. So what is it? Physical agents, physical damage, physical injury. What can be the causes of physical injury? Road traffic. So many. Road traffic accidents, any kind of trauma, radiation injury, burns, colds. Okay, like for example, one of my friends means he's even younger to you or maybe of your age. A few days back he went to, for this student exchange program, he went to Moscow. And he came back to Delhi, and from Delhi he called me up, showed me a picture. He has frostbite. That's also a physical injury because of extreme cold. So it can be burns, it can be cold, it can be radiation injury, it can be a trauma, it can be so many things. So that is the physical. They will not ask you this question. Don't worry, this question will not be asked. I have never seen someone asking such an easy question in examination. You're lucky enough to get this question. You won't. I'm pretty sure you won't. But at least you should know the causes. Physical. Number 3. To the left. Huh? What? Yes, what's your name? Bolo. Microorganisms. Yes, very good. So what are the microorganisms? Bacteria, viruses, fungi, parasites, protozoa, etc. etc. So many are there. Beyond my scope to explain. Beyond anyone's scope to explain everything. No. Excuse me. You know why I'm putting these pictures? It becomes easier for you to understand. Just putting theory you can study from the book. This becomes easy. Number 4, RX, means treatment. Chemical agents and drugs. Chemical agents and drugs. Oxygen at a high concentration can kill you. There's something called oxygen toxicity. Have you heard of something called the free radicals? Free radicals. I'll be explaining it tomorrow. Free radicals. Okay. Okay. This one, number 5, this girl looks very happy and all, but there's nothing to be very happy about it. When I'm explaining it in case of cell injury, what do you think it can be? What do you think it can be? Yes, let me see. Bakigulo to easy chilo. Hey, this one, the left, this one. Lifestyle changes, eita asche, eita ki? Quiz. Come on, tell me. Somebody tell me. Huh? Aging. Mone hocche aging. একটা পার্সন খুব হঠাৎ দেখবে একবারে হাসছে এই করছে. Yes, somebody said something. I heard the correct thing. Huh? Mental disability is correct. Yes, you said something? Somebody said something? Huh? Mental, yes, mental condition. A disbalanced mental condition. Sir, এটা কি হতে পারে? হ্যাঁ? কি? BPD মানে? Bipolar disorder অনেক হাই লেভেলে চলে গেল, কম লেভেলে. Yes, correct, but it's a good guess. You're trying. See, you're using your brain. I'll let you use your brain. So what can it be? Yeah? You have studied it. পরীক্ষার কোয়েশ্চেন আসছে. পার্কিনসন্স তো এরকম প্রেজেন্ট করে না. তোমরা পড়েছো এই জিনিসটা. You have studied it. Come on now, tell me. পরীক্ষায় কোয়েশ্চেন আসে. আচ্ছা, এটা অ্যানাটমিতে কোয়েশ্চেন এসেছিল. এটা this is just an example. এরকম অনেক আরো পিকচার দেওয়া যেতে পারে. Many prototypic pictures can be put, but I have just put one picture for you to easily understand. Yes. Huh? Hallucination. Try guess. Genetic derangements. Can it be Down syndrome? Edwards, Patau's. So this is basically Klinefelter's একটু বেশি একটা বাচ্চাকে এখানে Klinefelter's আসছি না. Let's think of Down syndrome. Or for example, let's think of cretinism. Can it be a genetic derangement? That's all. That's what I mean, genetic derangement. এখন আমি বললাম কি genetic derangement অনেক কিছু হতে পারে. So many genetic derangements can be put, but I have just put this one. An abnormal look, not abnormal, actually this may look very jovial, but আমি একটা prototypic example দিচ্ছি. আমি যদি লিখে দিই genetic derangements, you will not use your brain. This one, what is it? They are very similar, but this is what? Obesity. Means what? So obesity comes under what? Lifestyle modifications. Yes, lifestyle is a good answer, but I'm looking for something better. It's a good answer, but I need better. Junk food is not a very good answer, but correct. Lifestyle modification is better than a junk food That answer is better, but I'm looking for something probably the correct explanation. Obesity to boleche. Obesity and junk food and lifestyle modifications, they're all interrelated. Out of this, junk food, lifestyle modification is the best, but what is it called? Okay, you say obesity, you say junk food. There are people who don't even eat food. Some models circle binge eating. What they do is they eat and they put finger in their mouth and puke everything out, so they don't get nutrition. So what is it called? Now I have given you the answer. They all come under nutritional imbalance. So nutritional imbalance. Trust me, I'm telling you, biryani, do you think biryani is good or bad? Biryani, if you leave the biryani te ki kore, maximum dokane dalda deয়, which is bad. But if you make at home, make it with pure rice, put solid chicken or solid animal protein, eat with salad, very good for health. Only carbohydrate ekটু বেশি যাবে. That is the only thing which you can cut down on. And finally this one, what is it? We will kill you. This is an immunologic reaction. It will be tough for you, but this is an immunologic reaction. So what are the causes of cell injury? Now you tell me, what are the causes of cell injury? One is hypoxia, then physical trauma, physical agents like trauma, cold, extremes of temperature like excessive heat, excessive cold, burns, whatever it may be. Then physical agents. What are those agents? Physical agents is gone. Then what is the third one? Microbiological agents. Physical agents are gone. Then comes the microbiological agents. That is number 3. Then you get drugs and chemicals. So many things. Oxygen, arsenic, mercury chloride. So many things. Everything. একটা লাইন পড়বে তোমরা নিওপ্লাজিয়াতে, whatever we do for fun, pleasure, lifestyle, for daily requirements ultimately turns out to be carcinogenic. এই লাইনটা পড়বে তোমরা, রবিনসন লিখেছে। Okay, then comes number 4. Number 4 is a genetic derangement, then nutritional imbalances, and finally immunologic reaction. So this is what I mean. This is what I mean. Oxygen deprivation, various physical agents. আমি যদি শুধু এইটুকু দিতাম, you wouldn't have used your brain to analyze what I am teaching. So let it be an interactive session. Let it be an interactive session so that it becomes easier for you and easier for me to explain. Excuse me, and easier for you to understand. Very simple. So I think it's 10:50 and today wasn't a scheduled class, so I stop here and tomorrow I'll continue with the...
What is CSF? Cerebrospinal fluid. Cerebrospinal fluid is a fluid, mainly its action of shock absorbing between brain parenchyma and exterior. So cerebrospinal fluid, as we all know, present in all the 4 ventricles and the subarachnoid space up to the end of the spinal cord. So cerebrospinal fluid is secreted by the choroid plexus of ventricles and it is produced as well as reabsorbed by the choroid plexus depending upon the necessity of the body. It also acts as a blood-brain barrier. So, as a function of blood-brain barrier, cerebrospinal fluid or CSF has a role of giving nutrition to the brain parenchyma from the blood and draining the toxic metabolite from the brain to the blood. So, cerebrospinal fluid, it is a clear, in normal individual, it is a clear colorless fluid and its viscosity is as same as of water. In adult cerebrospinal fluid, the amount is nearly 50 to 150 ml, but in adults it is, in children it is 50 to 60 ml. So, in various diseases of brain, like in infection, like meningeal involvement, meningitis, and so glad to receive our Associate Professor Dr. Rajeshri as our student. Okay, now coming to the CSF picture in meningitis. So, as we all know, meningitis, what is meningitis? It is the inflammation or inflammatory involvement of the covering of the brain and spinal cord. So, meninges, as we all know, that it is a covering of brain and spinal cord. Whenever it is got inflamed by various etiological agent like bacteria or tubercular agent or fungus or virus, so meningeal involvement or meningitis occurs. So in meningitis, what are the possible changes of CSF? That is our topic of discussion today. First, as we can see in this picture, that mostly we will be discussing in 4 categories. Like first, appearance. So how the CSF will appear. Next is cell count or cellularity. How the cellularity will differ from various type of meningitis. Next, the protein in CSF, and last is the sugar. So, if we want to discuss about the abnormal things, we first have to know what is the normal. So, as I told you earlier, CSF appearance is colorless, clear fluid, viscosity same as water. But any kind of meningeal involvement, any kind of meningitis, whether it is bacterial, whether it is viral or fungal, this clarity of CSF will be lost. So, the clear colorless appearance will be lost. So, this is the first thing that we have to be suspicious when the color or appearance of the CSF is not clear as water. So, how will be the color of CSF in possible meningeal involvement? In bacterial meningitis, the appearance or color will be turbid or purulent. So, in bacterial meningitis, the appearance of CSF will be turbid and purulent. And the other types of meningitis like tubercular meningitis, viral meningitis and fungal meningitis, the appearance will be cloudy. So, in any kind of meningitis, the appearance is lost. The crystal clear appearance of the normal cerebrospinal fluid is lost, and in bacteria it will be turbid, and in other kind of meningitis it will be cloudy. Next, the cell count. So, coming to the abnormality in cell count, we have to know the normal range of the cell. In normal adult person, the cell count of CSF is less than 5. So, normal is less than 5. This is normal. The cell count of CSF or cerebrospinal fluid is less than 5 per DL in case of healthy young adult individual. In infant and children, the cell count is up to 20. So, in adult it is normal less than 5, and in infant and early adolescent, this cellularity, the cell count is up to 20 is acceptable per deciliter. This is normal. So, in case of meningitis, this normalcy will be lost. And in bacterial meningitis, the cell count of CSF will be much higher and it can go up to 1000 per DL. Up to 1000 per DL, it may be more, but from the text or from the evidences, we can see that the cellularity or the cell count of cerebrospinal fluid in bacterial meningitis is much more increased and can go up to 1000 per DL. And in tubercular, viral and fungal meningitis, this cellularity is also increased, but maximum number of cellularity or maximum number of cells we can get in bacterial group of meningitis. But in tubercular meningitis, it will be like 500 to 800. In viral meningitis, this is 250 to 500. And in fungal meningitis, it is also more than 100. So, invariably, despite of the etiology, the cellularity will be increased. It is maximum in bacterial meningitis, but all other type of meningitis like viral, fungal and tubercular meningitis, the cell count will be much more. And now the type of the cells. In normal adult individual or the infant, we see the normal count is, cell count is up to 5 in young adult and up to 20 in infant and early adolescent. And coming to the types of cell, the cells are mostly lymphocytes. Okay? The cells are mostly lymphocyte and monocytes. But in bacterial meningitis, this is predominantly the population of neutrophil. Okay? That is meningeal involvement by some bacteria like Haemophilus influenzae or like Streptococcus pneumoniae or by Neisseria meningitis. Whatever may be the bacteria, the cell count will be higher and the predominant type of cell is invariably the neutrophil or polymorphonuclear lymphocyte or leukocyte, PMNs. But in tubercular meningitis, the cellular population is mostly mixed. It is both lymphocyte and neutrophil. Okay? So in tubercular type of meningitis, the increased cellularity is attributed by the mixed population of cells. Mostly this is mixed of lymphocytes and neutrophils. Viral meningitis, the predominant population is also lymphocyte. Viral meningitis, the increased cellular count, the predominant cellular composition is mostly lymphocytes. And lastly, the fungal type of meningitis, the predominant cell count is, predominant cell type is lymphocyte and eosinophil. Okay? So, all other meningeal involvement, all meningitis scenarios, the cell count of the CSF will be invariably increased, but the population of the cell will differ from one etiology to another. Like in bacterial meningitis, the predominant population is neutrophil, and in viral meningitis, the predominant population of cells is lymphocytes. In tubercular meningitis, the predominant population is mixed population as well as lymphocyte and neutrophil. And in fungal meningitis, the predominant population is lymphocyte and eosinophils. Okay? So, the cell count portion is over. Now, coming to the protein part. So, again, from the other parameters,
we have to know the normal range of protein in CSF whenever we need to discuss about the abnormal C. Okay, so the normal protein value of cerebrospinal fluid is 15 to 45 milligram per dl. Okay, please remember the normal protein count or normal protein amount of cerebrospinal fluid in healthy young individual or healthy infant or child is 15 to 45 milligram per dl, that is 1% of the total serum protein. Okay, so normal CSF protein is 15 to 45 milligram per dl. So in any kind of meningitis, this protein value, this amount of protein present in CSF will be more, and anything more than 50 is suspicious or pathognomic. Okay, so 15 to 45 milligram per dl protein is normal range, and anything more than 50 milligram per dl is generally pathognomic and suspicious, and protein count up to 150 milligram per dl, that is 2 to 3 times more than the normal range, is invariably due to meningeal involvement or increased vascular permeability. In inflammation, we can see or we can remember the exudation of protein, that is from increased vascular permeability. The same thing happens in brain parenchyma also, and also the exudation of protein from intracellular space in CSF. So protein count or protein amount of protein is more due to increase in vascular permeability in meningitis. So in bacterial, tubercular, viral and fungal, whatever be the meningeal involvement type, the protein count will be more. So protein count will be more in every type of meningitis. Okay, and it is maximum in bacterial, more than equal to 150 milligram per dl. So in any kind of meningeal involvement, the protein amount secreted in CSF will be more. There are few conditions where in absence of inflammation, the CSF protein will be raised due to not in increased vascular permeability, but due to increase in intrathecal synthesis of immunoglobulin or gamma globulin. What are those conditions? Multiple sclerosis, Guillain-Barré syndrome. These two conditions have unique property of increased protein in CSF, but despite of increase in protein content in CSF, the cell count will be less. The cell count will be normal. So these two exceptional conditions have protein content in CSF will be much more higher, but this is not due to the increase in vascular permeability by some inflammatory agent. This is entirely due to increased in intrathecal increase of synthesis of protein within CSF. The two conditions are Guillain-Barré syndrome or GB syndrome, where we can get the gloves and stops like neuropathy, and the another one is multiple sclerosis, an advanced demyelinating disease where intrathecal synthesis of globulin is more. So whatever type of meningitis, whatever the etiology, the protein count will be higher than normal. Now coming to the sugar. Now coming to the sugar content. High, low, low because of utilization by the bacteria. ওদেরকে খেতে হবে, bacteria need to feed, bacteria need to be viable for their feeding purpose. They utilize the sugar present in the CSF. So in any type of meningitis, the sugar will be less except one, that will be a MCQ question. In bacterial meningitis, the sugar content of CSF will be less, even less than 40. In tubercular meningitis, the sugar, okay, but only the viral type of meningitis, this sugar is normal. This is the MCQ question. Which type of meningitis has got normal sugar value in CSF despite of meningeal involvement? The answer is viral meningitis. And also fungal type of meningitis, the sugar amount will be low. So the protein and sugar has an inversely proportional relationship due to meningeal involvement by any inflammatory agent. The protein will be increased due to increase in vascular permeability, but the sugar will be decreased due to utilization of the etiolopathogenic agent of the sugar in CSF. Clear everybody? So except one type of meningitis, that is viral meningitis, here sugar in CSF is normal. Okay. Now this is mostly the appearance, cellularity, parameters majorly differ in their values in various kind of meningitis. Now that other investigation or definitive investigation. What we can see in CSF when we suspect bacterial meningitis, so we can use gram stain, okay, for demonstration of gram positive or gram negative etiological agent or causative organism. Gram positive organisms like Streptococcus pneumoniae, gram negative organism like Neisseria meningitis. So coming to the definitive diagnosis, the CSF may need to be investigated by various special tests like gram stain and bacterial culture, okay, for the demonstration and isolation of the positive organism. Okay. Now same as tubercular meningitis, when you suspect the patient is suffering from tubercular meningitis, then what we can do from the CSF, that is Zn stain and for isolation of tuberculosis MTB, that is PCR or CBNAT, nucleic acid amplification test. So Zn stain and nucleic acid amplification test or PCR for demonstration and analysis from CSF whenever tubercular meningitis is suspected. Okay. Now coming to the virus, what will be the mode of diagnosis? Is there any stain to demonstrate virus? Any stain which can demonstrate any virus? Okay, assuming your answer is no, so and RT-PCR for demonstration of virus or viral etiological agent from CSF whenever viral meningitis will be suspected. And lastly, in fungal meningitis, what are the stains to demonstrate the fungal involvement or fungus? ওটা আছে ইন্ডিয়া ইঙ্ক, India pink, obsolete, and fungal culture. So, meningitis has got mainly 4 different types. Number 1 is bacterial meningitis, number 2 is tubercular meningitis, number 3 is viral meningitis, number 4 is fungal meningitis. And what we need to know? The appearance, the cell count, the types of cells, the protein and the sugar, all are altered in their own respective way. We need to know whichever have been increased, which cell population will be increased, protein will be increased or not, sugar will be decreased or not, and finally, for definitive diagnosis of the etiological agent, we need to do either gram stain or Jaden stain or India ink preparation and bacterial culture or fungal culture and polymerase chain reaction for better quantitative diagnosis of etiopathological agent. Okay, thank you.